गाडे सर, तुम्हाला मी फ्लायर पाठवले बघा व्हॉट्सअपला.
Okay, sir, we are
Gade,
on
sir.
live, sir, and
Yes,
we are
sir.
starting session. So, very good evening, doctors. I am Dr. Stalin on behalf of Shield Healthcare, welcoming you all for the today's webinar on USG updates. So, I welcome the chief guest of honor, and delegates and the chairpersons who are going to be who is going to be presented today in this webinar. So, without wasting time, I would like to hand over the session to Karishma ma'am, who is going to be the master of ceremony of today's session. Over to you, ma'am.
Thank you so much, Dr. Stalin. Very good evening to everyone. I welcome all the delegates, and let me introduce and invite Dr. Sadanand Ingre, President, Buldhana OBGY Society, and Dr. Vinod Rajankar, Secretary, Buldhana OBGY Society, organizers on the webinar dais. Dr. Sadanand Ingre, practicing obstetrician and gynec in Khamgaon since last 32 years, President, Buldhana OBGY Society, Vice President, IMA Khamgaon, performed large series of NDVH. Welcome, sir. Dr. Vinod Rajankar, sir, MBBS MD from GMC Nagpur, Secretary Buldhana OBGY Society. Current status, Director Rajankar Hospital and Sonography Center, Khamgaon, Secretary Indian Medical Association, Khamgaon branch. I welcome you, sir, and now I request Dr. Ingre, sir, to give welcome address to this webinar. Over to you, sir.
Ma'am, Dr. Ingre sir not joined it, ma'am.
Yeah, we can request Vinod sir.
Okay.
No, Ingre sir joined. Sir, unmute kara. Ingre sir unmute kara. तुम्ही unmute kara. Ingre sir, आता बोला. आता start kara. Yes.
It gives me a great pleasure to welcome you all to this great academic feast on ultrasound. I am very happy, very glad to introduce our honorable chief guest, Dr. Prashant Acharya. Dr. Prashant Acharya actually needs no introduction, and I don't have any words to describe him. I have attended his training courses many times, and I am a great fan of him. He is a fetal medicine consultant working in the Paras Fetal Medicine Center in Ahmedabad. He is also honorary professor in the Gujarat University, Fetal Medicine. He has got many firsts in the India on his credit. He is the first Indian to be appointed as a board member and trustee of the ISUOG. He is the first Indian to become ambassador to ISUOG for many years. He is the first Asian to be honored and awarded as a ISUOG fellowship. He is a board member of ISUOG Advisory Board. He was a vice president of FOXI. He is involved in many teaching and training programs in ultrasound. He has published many books and many articles on ultrasound. He has also published fetal growth and biometry charts. He has got a very rich experience in intrauterine interventions, especially intrauterine exchange transfusion in RH isomalized fetuses. And you all will be wonder if you know that the fetuses whose exchange transfusion was done by him when the fetus was in intrauterine, now they are 16 to 17 years old and enjoying a healthy life. He has also operated many cases of diaphragmatic hernia, intrauterine diaphragmatic hernia on the fetus. Now, his book 100 Thumb Rules in Obstetric Ultrasound is upcoming, and we all are waiting eagerly. Welcome, sir. Again, our another honorable chief guest, Dr. P.K. Shah. He also needs no introduction. He was very popular in students, and actually he was introduced to me by our Dr. Rajendra Singh only in Bangalore conference. I had got an opportunity to attend few of his CMEs in Aurangabad, Bangalore, and Mumbai. He's a great teacher. He is the first teacher to start ISUG recognized ultrasound courses in Sion Hospital, Mumbai. That's all. Thank you. Let us enjoy this great academic phase. Thank you.
Thank
you,
you so,
Yashwant.
yeah, thank you so much, sir. I would request Dr. Vinod Rajankar sir to introduce and invite Dr. Ajay Mane sir to process as convener of this webinar. Over to you, sir.
Hello.
Yes, ma'am.
Hello. Dr.
Yes.
Vinod is busy in attending some emergency. I will do his task introducing Dr. Ajay Mane.
Yes, thank you so much, sir. Sir, you can proceed with the CV, sir.
Some net problem is there, I think. You can continue. Ajay Mane sir will continue. Mane sir.
Over to you, Mane sir.
Ani, Karishma, you can continue by CV of Dr. Mane
Okay,
sir.
okay, sir. Dr. Ajay Mane, member NIMC, Government of India through FOXY, medico-legal consultant since 18 years, Chairperson official AMOX website, Chairperson Sexual Medicine Committee, Chairperson Adolescent.
Karishma, we'll skip that.
Okay, sir.
Thank you.
So I request you to introduce and invite Dr. Yashwant Gade sir, MMC observer
Can
to
we
our
have-
webinar. Yes, sir.
Yes. Thank you, Karishma. Thank you very much. And thank you, Buldana OBO Society. Dr. Yashwant Gade, the best person, best orthopedic surgeon from our region. And he is the Secretary IMA Aurangabad last 4 years and Central Working Committee CWC member, National IMA since 2 years. He is a State IMA Vice President 2022. He is Executive Member nominated of Maharashtra Orthopedic Association 2022. Organized numerous CMEs and conferences, all gold medals with rank 1 throughout MBBS curriculum at GMC Aurangabad. Professor at City Medical College, Durgapur since December 20, was Associate Professor Orthopedic in Government Cancer Hospital, Aurangabad, was Associate Professor in Government Medical College, Aurangabad, was lecturer in orthopedics in MGM Medical College, Aurangabad. Then he is a MUHS examiner for MBBS and MS and D Ortho. Is CPS examiner for FCPS and D Ortho. Consulting orthopedic surgeon at Gade Hospital, Aurangabad. And one more thing I would like to add, which is not there in the CV, he is a MPSC passed, worked as a deputy collector for 6 months. And with the all corruption mahol, he left service and again came to the noble profession of this Dr. Key. And he is serving the people. And most great thing about him that he has trained many students, including me. I am very proud to be his student. I have used his notes during my MBBS tenure. We have not used a single book of orthopedic. We have read only his notes and we have passed with the flying colors. That is the greatness of this person. And I welcome Yashwant Gade sir and I request you to kindly bless us. He is a MMC observer.
Yeah, thank you. Thank you, Foxy. Thank you, Buldana Gynecological Society. My senior, Dr. Sadanand Ingle. My senior, Dr. Rajendra Singh Pardesi. My colleague, Dr. Ajay Mane, convener of this webinar. Esteemed faculties, Dr. P.K. Shah, Dr. Archana Patil, and other faculties who are very distinguished in their field for organizing and this USG update in gynecology. So I'm very happy that I have been appointed by MMC as observer for this webinar. I wish all the best and all the success to you, Dr. Ajay as convener, and Dr. Rajendra Singh Pardesi and Dr. Sadanand Ingle. Thank you so much.
Thank you
Thank
so
you, sir.
much, sir.
Thank you, sir. Thank you very much.
Thank you, sir, for gracing our webinar. Now moving on, I would request Dr. Ajay Mane sir to introduce and invite Dr. P.K. Shah sir, past President Foxy, to share some words of wisdom for this webinar.
Yes, great. Today we are having chief guest, Dr. P.K. Shah sir. We, with great happiness and honor, call him as Bhishma Pitama of Foxy. And he looks like Bhishma Pitama also. In Corona era, he has changed his look basically. See how kind he is in this photo and see how he more kind in actual appearance. He is guru of Rajendra Singh Pardeshi sir and my mentor from Foxy. He is past president Foxy, past president IFUMB, past president ICMU, past chairperson Imaging Science Committee Foxy, started first Foxy recognized training center. And he is pioneer in sonography for the gynecologist. That is the best thing. And he has trained thousands of the gynecologists and obstetricians in India. He has instrumental in making resolution by MCI that any doctor having MDMS, DGO, DNB or MCI recognized qualification in OBGYN can do ultrasound, which was not there previously. That is the best achievement he has achieved today. And we are very much thankful to you, sir, for this thing from the bottom of our heart. He was instrumental in getting journal Foxy indexed with the PubMed Central. Yes, I welcome you, sir. आणि तुमचा मोठेपणा आहे की irrespective of with such a busy schedule, you have given time. Sir, welcome, and I request you for the blessings.
Thank you, Ajay, for your kind words. And at the outset, let me thank Buldana OBGYN Society and office bearers, especially Dr. Sadanand Igle and Dr. Vinod, for giving me this opportunity to be with you all in this webinar. It is so nice to have guests of honor in the form of my colleague, Dr. Prashant Acharya, and my student, who has become now teacher of many, Dr. Rajendra Singh. I appreciate Dr. Ajay Mane for doing so many webinars. Wherever I have been a participant in a webinar, I have always seen Ajay. So I don't know at this rate how many webinars he is being involved. All the best for your future activities and for whatever you do in future. I think I have a first love in the form of ultrasonography. And when I started training gynecologists, the only reason I had in mind is that no one wants to train gynecologists, ultrasonography in obstetrics and gynecology. So I took up this challenge. Initially, we had 2 students, 3, 5, like that. It kept increasing number of students. It came to almost 20, 25. And then we restricted it to only 20 later on. But I'm very happy that I must have trained about 700 students amongst Foxy members as a single faculty by doing hands-on training in transabdominal transvaginal sonography for 15 days. Many of them have surpassed my knowledge and stature, and have become very good teachers. That makes me very proud. And when I see any webinar where ultrasound is involved, I can't say no to be a part of it. So thank you, Rajendra Singh Pardeshi, Ajay, and office bearers of Buldana OBGYN Society. It's fabulous to see fantastic faculty, because today's topics are very specific, like double bubble, preeclampsia prediction in first trimester, color Doppler in third trimester, and medico-legal aspects of ultrasound. Ajay, I know you are going to cover medico-legal aspects, but one thing you must not be knowing is that there is a case going on an ultrasonologist for heating the patient with TVS probe. It appears very funny, but these are the things that can happen in life. things can go wrong, to what extent. But I'm sure we'll enjoy your talk also. And we have none other than Dr. Archana Patil, Dr. Bela Bhatt, Dr. Ajay Mane. What is more important is selection of chairpersons. Dr. Sita, who was at Sion Hospital with us for many years, and Dr. Bhaskar Pal's wife, Dr. Sita Ramurthy, Dr. Veena Panath, very much from Aurangabad, and Dr. Sujit Konkar. So nice to have selection of so many people like this. I'm sure we are going to have a fantastic evening. Let us not waste time, because as such, the topics are going to be covered in depth by all of us. Thank you very much for making me a part of it. I wish you all the very best for this webinar. Thank you.
Thank you so much, sir.
Yes.
Thank you so much. Moving on, I would request Dr. Ajay Mane, sir, to introduce and invite Dr. Prashant Acharya, sir, past President Foxy, and our guest of honor. Over to you,
Thank
sir.
you. Thank you, P.K. Shah, sir, for being there. Our next guest of honor is Dr. Prashant Acharya, who is again a star from Gujarat. He's a past president, past vice president, Foxy 2012, consultant in fetal medicine in high risk pregnancy care at Pars Advanced Center for Fetal Medicine, Ahmedabad, diploma in ultrasonography, diploma in pelvic endoscopy, Germany, trained at King's College of Hospital, London, England, chairperson, genetic and fetal medicine committee, Foxy 2010 to 12, then honorary sonologist, Shet KM School of Postgraduate, then first Asian to be inducted as a ISUOG's board member in 2015 and 19, with which he has given us one conference on sonography, which we conducted in Aurangabad. Thank you, sir. And he's been appointed as the ISUOG's ambassador for India and South Asia. I welcome Dr. Prashant Acharya, sir, a star speaker and a very stalwart personality, very sweet fellow from Gujarat. And I welcome and I request you for the
Ajay, congratulations. And sorry. Hello.
Yes, sir.
Yes,
Yes,
sir.
sir.
Yes, sir. You are audible. Yes, sir. Yes, sir. You are audible. Yeah, he's in travel, so the network must be an issue.
So we will
I'm
wait.
sorry, I'm traveling. So the Dr. Pardesi and Dr. Ajay Mane, they are both as a team. They are phenomenal, and they are going to take care. And I hope everyone will learn, and everyone should. And I also know Sadanand Ingle. Sadanand is really a gem of a person. I know him personally, and because he is attending so many of the courses which Parasis which we are organizing. So what I feel is all the very best for your webinar today evening, and hope everyone will enjoy.
Yes, thank you.
Thank
you,
you,
Prashant,
sir.
sir. Thank you very much.
Thank you so much.
The next slide.
Sir. Yes, sir. Now I would request you to invite and introduce Dr. Rajendra Singh Pardesi.
Yes.
Yes, sir.
Yes, Dr. Rajendra Singh Pardesi, my mentor and the backbone of Aurangabad Obedience Society. Great person.
It's okay, just keep it. Just keep it. Ajay, we are lagging behind schedule. Good
yes,
afternoon, everybody. Respected Dr. P.K. Shah, sir, Dr. Prashant Acharya, Dr. Bela ma'am is Imaging Science Committee Chairperson, Dr. Sita, and Dr. Archana and Dr. Ajay Mane. All are stalwart in the field of genetic and fetal medicine and sonography. So we wish to hear you all the facts and the applications in our day-to-day practice. So I wish every success to this webinar and every success to the activities of the Buldhana Obijaya Society, and I wish every success to Dr. Ajay Mane also for his future endeavor as a Vice President Foxy election, and to Dr. Sita Pal also as a Chairperson for Genetic and Fetal Medicine Committee. I hope she will be unopposed. So I wish every success to this webinar. Thank you. Thank you so much. Thank you.
Thank you, sir. Thank you very much for the blessings.
Thank you so
you are
much.
a brain behind all these webinars. So I thank you from the bottom of my heart. Over to you, Karishma.
Thank you, sir. Thank you so much, Dr. Pardesi. Moving on, I would like to introduce and invite our chairpersons. Dr. Sujit Kondkar, UK Certified FM Specialist, Dr. Veena Panat, and Dr. Sitha Ramamurthy. Can we have Dr. Sujit Kondkar CV, please?
Yeah, I'll introduce Sujit Kondkar, Karishma.
Okay.
Let me do the favor. He's an MBBS and MD from Government Medical College, Aurangabad. Basic USG training at Dr. Bimal Sahni Sonoscan Center. FMF certified many subjects, including fetal abnormalities. Now he's the secretary of Society of Fetal Medicine, FMF Markoda chapter, and his center, Sri Hospital, is a FOXY approved USG training center. Are interested in advanced fetal ultrasound. And he's a cricketer as well as he's a best singer of our society. So a very pure soul from Aurangabad and very thorough academician. As P.K. Shah sir said, there should be students who are brighter than the teacher, and likewise Sujit is there. I welcome Dr. Sujit Kondkar. And next CV, please. Yes, Dr. Veena Panat. She is a MD OBGY from Government Medical College, Aurangabad, consultant at Panat Hospital, Aurangabad. She is ex-president Aurangabad Obgyn Societies. As a GS of Society, Aurangabad Obgyn Society won the National FOXY Dr. D.K. Tank Trophy. Then AMOG's Infertility Committee member. She is ex-member of FOXY Imaging Science Committee and FMF accredited doctor and fetal abnormality scans. Then was national faculty at FOXY, and she has got many credentials with her, and she's been working in social as well as academic field. I welcome Dr. Veena. Next CV, please. Yes, and the senior most chairperson of today is Dr. Sitha Ramamurthy Pal. We know her from both sides, from Maher and Sasar, that is from Bhaskar Pal sir and from Ruli. She's consultant fetal medicine and obstetrician, Apollo Gleneagles Hospital, Kolkata. She's MBBS DGOMD from Mumbai, then FICOG, FRCOG. We have heard about these degrees only, never gone to such places. She is a stalwart. RCOG, RCR Diploma in Advanced Obstetric USG. He is a Joint Clinical Secretary, Bengal OBGYN Society, 2021. She is a member RCOG, Eastern Zone Representative Committee, and honorary treasurer, Society of Fetal Medicine, Kolkata chapter. She is the clinical secretary, ASOPAB, Kolkata chapter. She is East Zone coordinator, Imaging Science Committee, FOXY, 2018 to 21. She is been examiner for the MRCOG Part 3, which is the last part, and faculty MRCOG Part 2 and 3 courses. And she is a member, National Board Specialist Committee of Maternal and Fetal Medicine. And I congratulate Madam for your unopposed win in the chairpersons. Maybe after 4 days they will declare. Maybe 4 days they will be declaring, but you are unopposed. So I congratulate and I welcome you, ma'am, as a chairperson. And thank you. Over to you, Karishma. Over to you. Ma'am, your connection seems to be, you are not audible clearly. Okay, we move on to our academic session now. Yeah. Chairperson Sujit, will you introduce Dr. Archana Patil?
Yeah, sure. Good evening, friends, colleagues, and seniors. I'm very glad to introduce Dr. Archana Patil. She is consultant fetal medicine at Medico Hospital and International Hospital, Aurangabad. She has done her fellowship in advanced obstetric ultrasound at Fernandez Foundation, Hyderabad. She has done certificate course in advanced fetal echocardiography at Rainbow Children's Heart Institute, Hyderabad. She is clinical secretary of Aurangabad OBGYN Society. And another thing, she creates very good Marathi poems. This is another part of her that is not mentioned in her CV. So I invite Dr. Archana for her talk. Dr. Archana, please.
Sita ma'am, can I request you to express your thoughts? You were saying something. The connection problem is there. Sita ma'am, are you there?
I'm here. Can you hear me?
Yes, ma'am.
Can you hear me?
Yes, ma'am.
Yes,
Yeah,
yes.
I said I was just thanking you and Dr. Pardesi sir for giving me this opportunity to be part of this wonderful session. And best wishes. Thank you.
Thank you, ma'am. Thank you very much. Over to you, Archana.
Thank you, Dr. Sujit, for an lucid introduction. Thanks to Buldana OBGYN Society and Shield Connect for giving this nice opportunity for this today's talk. So my screen is visible.
Yes, ma'am.
Can you make it a full screen?
Yeah. So is it visible now, sir?
Yeah, it's visible, but not full screen.
Yeah, it's full screen, sir. Right now it's full screen.
No, just stop sharing. Chitrakala, are you there?
Yes, sir. Yes, I am there,
Yes,
sir.
kindly guide.
Sure, sir. Ma'am, please stop share, ma'am.
Okay.
Share once again, ma'am.
Yes.
While sharing, please don't click any of the icons, ma'am.
Okay.
Click share screen and then blue color share. That's it, ma'am.
Fine.
It's it to be shared. Yes, ma'am. Fine, ma'am.
Yes,
Thank
yes,
you.
correct.
So thanks for the Buldana Visualized Society and Shield for giving this today's opportunity. Good evening to all the respected stalwarts which are attending today's live webinar. And I would like to start my talk with Man Vandana to Gurus, Dr. Pradeshi sir, the father figure for me, Dr. P.K. Shah sir, pioneer of obstetric ultrasound, and Dr. Prashant Acharya sir, my role model in the fetal medicine. So would like to proceed with the today's talk, that is the double bubble sign and its differential diagnosis. Dr. Sujit already depicted the same topic before words, but it would be like just a revised session and some added points with regards to that talk. It was quite a nice talk by Dr. Sujit. I'm not able to move the slides.
Click on the slide.
Please click on the slide.
Okay.
Yes, ma'am.
So the classical diagnosis of duodenal atresia is a double bubble sign. Instead of a single double bubble, which is instead of a single stomach bubble, which is seen in the AC plane, there are two bubbles which are seen in the double bubble sign. That is pathognomic of the duodenal atresia. But see, these two unequivoc shadows, when they are present in the AC plane, we have to have some things in our mind to differentiate those lesions, as some cystic lesions also contribute to this double bubble appearance. So although this sign is particularly for the duodenal atresia, but in terms, rather than depicting it as a double bubble sign, the two bubble differential diagnostic sign should be the topic. So this is the thing. Here is the normal AC plane. Here you can see the spine. Here the normal single stomach bubble, and this is the portal vein, which is the normal physiological structure when we see at the AC axial plane. And here it is presented the double bubble typical sign, stomach on the left side with communication, and the single other unequivocal lesion which is present right side to the left-sided stomach, which contributes to the double bubble sign. Again, Dr. Palladini has beautifully depicted the differential diagnosis based on the quadrants, that at what quadrant which are the particular diagnosis to be made. I'm not going to detail, it will take more time. So there are some cystic lesions, some intrinsic causes, some extrinsic causes, and some physiological causes which contribute to these two cystic lesion findings, which are often seen in the AC plane. So the first and foremost is the congenital duodenal duplication. It is the rare entity, and it contributes to 5 to 12% of all GI duplications which are seen in the ultrasound. The typical ultrasound feature is this presence of the muscular port, which lacks in other two cystic lesions, mainly the mesenteric cyst and the choledochal cyst, which can be termed or taken as the differential diagnosis, in particular when the cystic lesions are concerned. Second is the mesenteric cyst. It may be unilocular or the bilocular with septi can be seen, and the peculiar picture or feature we can say is its alteration of the shape by pressing the ultrasound probe across the abdomen of the baby. The fine thing is prognosis is good, can be detected good ultrasonically, and surgical intervention for which is not mandatory or required. The third thing is the polydactyl cyst. Here you can see the gallbladder. Here this is the polydactyl cyst. So again, two bubbles are seen in the AC plane. So how to differentiate ultrasonically these two things? Like, see, this is the polydactyl cyst. This is the dilated cystic lesion which communicates with the bile duct on either side, and it is seen differently or separately from the gallbladder. Actually, this needs surgical correction post-natal life, so we need to be particular in diagnosing the condition. Again, ovarian cyst, which is gender-based. Again, we need not to talk that this is only seen in the female fetus, but as we are not going to mention the sex of the fetus as it is banned in India, we need to say that this is the gonadal cyst and we need to give the differential diagnosis. So in the AC plane, how it looks and how it can be differentiated, that it present in vicinity to the urinary bladder if you go by the coronal section, and in the axial AC plane, these are the small cyst, daughter cyst, which can be pretty visible in the ultrasound. So it can add the diagnosis of the ovarian cyst. Again, these are the cystic lesions. So we are going to see some physiological lesions where we can misinterpret that, although these are the physiological, but they can be pathological. So this is the peristaltic, normal peristaltic wave of the stomach, which can be seen in the fetus. And when we are doing the ultrasound scan, so by observing this normal peristaltic wave, we can differentiate or we can diagnose it as a double bubble, because it has got the typical two bubbles with the intercommunication area. So what we need to do, that we need to stay apart for the 30 minutes, again observe the stomach. This is the stomach after this peristaltic wave. So whenever we are doing the ultrasound, keep in mind the dictum. Always think the commonest thing first and then go for the pathological thing. I apologize for not having the video clips, because of if video clips will be there in this talk, it could be very beautiful and understanding presentation. Again, meconium in the transverse colon. Sorry for the poor image. Here is the meconium studded intestine. Here is the stomach. But as per our knowledge of the diagnosis, this left should be, and this another anechoic lesion should be on right side to mimic it as a double bubble sign. But again, in the AC plane, these two bubbles are present. So this is again contribute to the two bubbles. But here it is the normal meconium which is present in the fetus, and we can appreciate easily physiologically at term at 36 weeks of gestational age. But if the dilatation is more, there are the dilatation criteria to depict the obstruction, intestinal obstruction. So that is the not part and parcel of this talk, but we need to remember that as well. Again, this is the incisura angularis, which is the normal anatomical physiological part which is seen in the antrum of the stomach. So here again we can wrongly mistake with the diagnosis that this is the one bubble, this is the second bubble, there is an intercommunication present, so this is the double bubble sign. So always look for this incisura angularis which is present, and it is the normal physiological thing which is present in the ultrasound, and it is not the pathological, and don't misinterpret as double bubble sign. So embryology and the consideration. At 5 weeks, as the primitive gut tube develops, the endoderm proliferates and occludes the entire lumen from the esophagus to the anus. At 7 to 9 weeks, expansion of the mesoderm and endodermal apoptosis causes the recanalization. Here, the recanalization process is pretty important in development of this atresia. Here, the hollow gut tube, which goes into the luminal occlusion by endoderm, and there occurs recanalization, and there is a defective hollow gut formation. All the GI abnormalities, they are developed or they are a result of the vascular insult. But as far as the duodenal per se, duodenal atresia is concerned, the failure of recanalization is the reason for that. Again, I'm not going to detail into this. The things that I mentioned, with rotation of the gut tube, the duodenum becomes retroperitoneal. Initially, the lumen is obliterated and later on it recanalizes. And if failure of recanalization produces the duodenal atresia. So we are about to discuss the major cause, that is the definitive sign of the double bubble, that is the duodenal atresia. So the male and female preponderance is 1:1. The risk of chromosomal association is pretty high, that is 20 to 50%, with particularly trisomy 21. Another, again, genetic association can be seen, that is deletion of chromosome 22q11, deletion of chromosome 22q24.3, mutation of gene MYCN, and malfunction of the fibroblast growth factor. But the risk of non-chromosomal syndromes with these particular signs is less, or duodenal atresia is less. So the outcome, good if it is isolated. The pathogenesis is not known. Suggested theories I already mentioned, recanalization and the vascular injury. Then diagnosis at 19 to 21 weeks. When the patient comes to you for the mid-trimester scan, the diagnosis is very difficult because these are the evolving lesions and particularly seen in the 28 weeks of gestational age. Only the evidences supports that the early diagnosis of this duodenal atresia is, in literature, only one case depicted at which is diagnosed at 14 weeks of gestational age. So what are the things there are, or warning or alarming signs that are seen in the mid-trimester scan to look into for the evolving lesion? Particularly polyhydramnios is absent in those cases. It may be the late second trimester, early third trimester polyhydramnios. Then double bubble has not completely yet developed because not that much amount of liquor is ingested by the baby to develop that double bubble typical sign. Evidently, what the main thing is, evidently dilated stomach with mild dilatation of the duodenum is the peculiar sign, and which should raise alarm in the mind that we need to look into for the duodenal atresia or the double bubble sign, which is about to develop at 28 weeks of gestational age. These are the normal stomach parameters which we always look into when the stomach crosses the midline to measure these things. Again, there is the gastric ratio, area ratio, which can be termed, but not that standardized parameters are available for those things. Here, the typical double bubble sign, as I mentioned, here the stomach, the duodenal part, and this is the communication. The communication should be looked in or should be present for to say or mention it as a double bubble sign. Then during the follow-up scans, the classic double bubble sign is clearly visible. As I mentioned, at 28 weeks of gestational age, it means a third trimester. Then there should be communication, as I mentioned, to mention it as a double bubble sign. Sorry for the poor image. See, we can depict these communication by means of the color Doppler. Color Doppler not only used for to screen or image the vessels, but also we can depict the flow of the fluid by means of the color Doppler. Here you can see the red and this is the blue, which is seen across this communication. So it confirms the diagnosis of the double bubble sign. When it is associated with duodenal stenosis, double bubble is visible in the late gestation. Evidence of constantly dilated stomach with pallorem is the partial obstruction sign. When associated with esophageal atresia, because in almost 33% of GI tract abnormalities are associated with this duodenal atresia. So if it is present or associated with esophageal atresia, over distension of the stomach with and proximal duodenum is particularly and typically massive. Again, it is associated with 30% of the cardiac abnormalities. It has close association with the Down syndrome, and intestinal malformations are pretty common with. Again, the abnormalities of biliary tract and pancreas, if they are present, it carries the poor prognosis, and non-visualization of the gallbladder is indication for the life-threatening biliary atresia. What can be the management protocols or principle when you see this double bubble sign on the ultrasound? So the karyotyping is mandatory because of its stronger association with trisomy 21. Detailed structural survey as associated cardiac and GM malformations. Then fetal echo. Gallbladder should be searched off because absent gallbladder is one of the sign for the biliary atresia, which is life-threatening condition. When the polyhydramnias it is present and the patient is symptomatic, then amniodrainage can be considered. And always remember that whenever you come across such patient of duodenal atresia or double bubble sign on the ultrasound, then the delivery should be done in the tertiary referral center. The postnatal approach, it can be by the surgical approach, determination by the anatomic findings after opening the abdomen. That is, some things we can miss by the ultrasound findings. So open the abdomen, see the other associated findings and go for further surgeries. Then bypass procedure can be done in the form of duodenostomy or duodenojejunectomy. Additional surgical procedures accordingly with the present malformations. Prognosis and survival. Early postoperative mortality rate is 3 to 5%. Late doesn't exceed the 6% of rate. Then again associated with severe biliary tract abnormalities, so also associated with the 20 to 40% neonatal mortality rate. There are late consequences of those surgeries as well. These are megaduodenum, duodenogastроesophageal reflux, and the peptic ulcer development. This is the intrinsic cause, that is the main cause of double bubble. Then we are looking for the extrinsic causes of the double bubble sign. Here again, the annular pancreas also contribute to the double bubble sign on the ultrasound, as these pancreas that obstruct the second part of the duodenum. Although the sign is pretty visible in the form of double bubble, but the confirmatory diagnosis is by means of the MRI. So we need to do MRI again in these cases to confirm our diagnosis. Again, another peculiar sign we can see on the ultrasound is the reverse peristalsis. Apart from this, wherever the obstruction by means of this pancreas are present, from henceforth we can see the reverse peristalsis in the intestine. Again, volvulus is not part and parcel, but like whenever the Ladd's band is the reason for contributing factor for the double bubble sign, it can be presented with a volvulus. What are the Ladd's band? The mesenteric attachments, first described as a cause of congenital duodenal obstruction by American surgeon William Hillard in 1932. As we know that normally in the fetal life, the intestine rotates 3 times in total duration. So failure of that rotation may present into the or resultant into the Ladd's band formation. These bands pass over on the second part of the duodenum and they cause obstruction and mimic the double bubble sign. These are the Ladd's band. They are crossing over and passing through the second part of the duodenum. So they can't be diagnosed on the ultrasound again. We need to suspect only. One more peculiar sign that can be diagnosed is the superior mesenteric artery vessel course. So by means of this talk, what are the take-home messages? Whenever we are coming across the abdominal cyst, there is the exhaustive list of the conditions. So we need to take into mind what is the differential diagnosis when 2 cystic lesions that are seen in the AC plane. Follow the systematic approach to rule out those conditions. Whenever possible, put color to denote the vascular origin or to denote the intercommunication. Then what are the checklists for the diagnosis? These are the location based, whether it is a simple or complex. Then we need to see the evolving lesions, which can be seen in the third trimester, as these are the, I'm sorry. Okay. So what are the per se, whenever we are dealing with the double bubble sign, what can be the things we can remember, or we need to take into our mind as persistent fluid which is present in the duodenum that is always abnormal, and we should establish the communication between two lesions to diagnose that condition. Evolving lesions we should search for in the third trimester, and we should keep in mind that this is the major marker for the trisomy 21. So accordingly, we need to do the karyotyping for the lesions. Then the same thing. These are my references for this talk. Thank you.
Thank you so much, ma'am. Now I would request our chairpersons to give their expert comments on these. Dr. Konkar, sir.
Yeah. This has been a very nice and excellent talk by Dr. Archana. She has covered almost everything regarding duodenal atresia and double bubble sign. She has covered very nicely embryogenesis, and most importantly, she has taken everything regarding the differential diagnosis, which is very important when you see two bubbles here. And rightly said, by and large, the prognosis of isolated duodenal atresia is good. It is very worrisome when we see when associated biliary system anomalies are there. I would like to add two more signs in connection with this. One is lateral sign, which is seen in duodenal diaphragm, and another is Pliers sign, which is seen in case of annular pancreas. I would like to have any more comments from Pal ma'am.
Yes, ma'am.
Sita ma'am.
Yes, thank you. Thank you, Dr. Archana. That was very comprehensive, covering all aspects. Thank you for an excellent talk. What I would say very important is that it is important to realize that some of the anomalies are evolving as the fetus evolves throughout the gestation. This is one particular major anomaly which catches us unawares. Even if the second trimester anomaly scan was normal, we can detect this later in the third trimester. And that is very important to counsel the patients accordingly, and important again to counsel that we should have a diagnosis, even if it's a major anomaly diagnosed in the third trimester, we should have a diagnosis, and for that an invasive testing should be offered. At least it should be documented. Again, Dr. Mane will tell us better. It has to be offered, recommended. What the patients take is their choice, but all invasives are not for termination. We also need to be prepared beforehand before the baby delivers as to how we can best address this baby. And very important, when these anomalies are diagnosed, as she rightly said, look out for other anomalies and have them have a consultation with a pediatric surgeon, because if it is really isolated, we have to be very positive about the entire pregnancy, that these children do very well, they have a normal life, and they talk to the pediatric medicines and pediatric surgeons, they get more input as to how these babies do. So that again is important. We have to look forward and counsel the couple accordingly. That's all my comments would be. Thank you again for your wonderful talk.
Yeah. Thank you, Sita ma'am.
Veena ma'am.
Unfortunately, Archana's Veena is not there.
Okay.
Unfortunately, Archana's video was not playing basically. So can I request Dr. Sujit Konkar? I have seen one video in one of your presentation about double bubble. Can you show that present?
Yeah, sure.
Available on your laptop? Yeah, please. This is my request from my side.
Yeah,
so that
I'd like to share my screen.
We had an excellent talk. We heard him talk yesterday in the SFM meeting.
Yes,
that was excellent.
She has covered everything.
Excellent videos. Now, Dr. Sujit has talking. So yeah.
Yeah. This is the video. Yeah, this demonstrates the continuity between the two bubbles. See, this is the continuity. And this is very important in confirming the diagnosis of the duodenal atresia when you see two bubbles.
If it is not communicating, then
Then you have to think of the other differential diagnosis.
Okay. Likewise.
Okay. I'll stop sharing then. Is it sufficient?
Yes.
Ajay?
Yes. Thank you.
Thank you so much, sir. Moving on. Shall we move on, Mane, sir?
Yes, please.
Okay. Moving on, I would request Dr. Konkar, sir, to invite and introduce Dr. Bela Bhatt to give a talk on prediction of preeclampsia in first trimester. Over to you, sir.
Welcome, Dr. Bela Bhatt, ma'am. I would like to introduce you. She is Chairperson, Foxy Imaging Science Committee, 2020 to 2021 to 23. She is FMF UK Certified Sonologist for Fetal Abnormalities and other things. For nuchal scan, she is member of SFMM, Society of Maternal Fetal Medicine, member of Society of Fetal Medicine, Scientific Secretary, AFG Mumbai. She is fetal medicine consultant at Dr. Babasaheb Ambedkar Memorial Center, Railway Hospital, Mumbai.
I think that's enough, Dr. Sujit. We should continue with our academics.
Okay, and she is a very good singer. I have, this is not mentioned in here.
All artists are gathered together.
वही बोल रहा था मैं कि वो सिंगिंग का पोएम करने का बात इसमें लिखा है नहीं किसी में.
Must be written additional qualification.
Additional qualification.
Yeah, can I share my screen?
Okay, yeah, sure, ma'am.
Yes, please.
Just to start your.
Okay, I just.
Bela's husband is much more greater medico-legal consultant than me. So no, she may cover my lecture also.
So I'll just start my slideshow first. So at the outset, I'm extremely thankful to Buldana OG Society for giving me this opportunity to be with you all here today. I'm extremely thankful to President Dr. Ingale, Secretary Dr. Vinod, and especially thankful to Dr. Pardesi sir, who has been the most supportive and friendly figure and guide for me in Foxy. So thank you so much, Dr. Pardesi sir, for giving me this opportunity to be here, and to have Dr. P.K. Shah here in front, with all of us is again a great honor. Also, thank you so much, Dr. Ajay Mane, for giving this opportunity to me. So without much ado, I'll start my presentation. So we are going to discuss about prediction of preeclampsia in the first trimester. Well, friends, I know that we all have basic idea about prediction of preeclampsia, and we all have been using it since at least couple of 2, 3, 4 years. But I'm just going to emphasize on some of the important points here, and my talk is a little exhaustive, so please bear with me, but still chairpersons can stop me when the time is about to be over. So we all know why we are worried about prediction of preeclampsia, because it complicates 2 to 8% of pregnancies and is a leading cause of maternal fetal morbidity and mortality worldwide. Early onset preeclampsia is a huge public health burden. We'll see the difference between early and late onset preeclampsia in my slides. And therefore, prediction and prevention should be a part of public health strategy and our social responsibility as obstetric community. Now, the basics here have to be clear that the definition of preeclampsia has been revised, right? ISSHP and ACOG in 2018 said that it is not just hypertension with proteinuria which makes preeclampsia, right? Any new onset hypertension more than 140/90 at or after 20 weeks with any one of the following, that is either proteinuria or renal involvement with serum creatinine more than 1 milligram per deciliter, or liver involvement with raised SGOT, SGPT, or neurological complications like eclampsia, altered mental status, blindness, stroke, clonus, severe headaches, persistent visual scotoma, or hematological complications like thrombocytopenia, platelet count less than 1.5, or uteroplacental dysfunction. This also has been included in the newer definition, that fetal growth restriction or abnormal uterine API or stillbirth. These are all, if they are accompanied by hypertension in pregnancy beyond 20 weeks, then they are termed as preeclampsia, and we are looking at all these when we are talking about preeclampsia. So why we are worried about preeclampsia? Because of potential maternal complications, which I'm sure all of us have seen either during our residency or throughout our practice: eclampsia, hepatic failure, renal failure, cerebral hemorrhage, pulmonary edema, or fetal complications because of the placental hypoperfusion. So, as I said, it's important for all of us to understand as to there are two categories of preeclampsia. One is early onset, another one is late onset. And early onset is the one which develops and requires delivery at less than 34 weeks of gestation, whereas late onset preeclampsia develops after 34 weeks of gestation. Now, what is the difference between the two? Early onset preeclampsia comprises only 10% of all cases of preeclampsia, right? Just 10%, but it is severe form of preeclampsia. There is major placental dysfunction which is seen in early onset preeclampsia, and therefore you'll get all our Doppler abnormalities, severe fetal growth restriction, maternal perinatal morbidity and mortalities, impaired renal function. All severe complications that we have ever seen are associated with early onset preeclampsia, and therefore our focus is mainly to try and prevent these early onset preeclampsia, though it comprises of 10%. Whereas late onset preeclampsia is the one which develops after 34 weeks. It's usually milder, and there can be normal or large for gestation age fetus at delivery at term. Now, whenever we are talking about prediction and prevention of a condition, we must first know about the pathophysiology of it. So what is the pathophysiology of or the root cause of preeclampsia? So we know that in preeclampsia, placenta is the organ of origin, whereas maternal endothelium is the target organ. So what happens in normal pregnancy? There are two waves of trophoblastic invasion. The second wave of trophoblastic invasion, which is almost from 16 to 20 weeks, is the one during which the small spiral arteries are converted into greater diameter, low resistance, and high compliance vessels. And because of this, there will be great increase in the flow in the uterine arteries. Now, whenever this change or remodeling in the uterine artery or spiral artery does not occur, that is the time when preeclampsia develops. Because this leads to placental underperfusion, hypoxia, ischemia, leading to release of numerous factors into the maternal circulation, which is ultimately leading to preeclampsia. So, whenever we talk about screening of anything, first thing is which population should we screen for? So as far as screening for preeclampsia is concerned, remember, like aneuploidy screening, here also screening is for all women. It is not just based on history, obese, PCOS, past history of diabetes, etc., etc. No. Then if you take just history into account, you are going to miss 60 to 70% of females who are going to develop preeclampsia who are just low risk based on history. So first message here is screening for preeclampsia is for all. Now, whenever we talk about screening of preeclampsia, two important aspects that we have to remember is about the availability of tests for screening and the cost of it. So throughout my presentation, we'll try to see as to what are the options available to us and which all can be used for prediction of preeclampsia. So we are talking about early prediction of preeclampsia at 18 to 13 weeks, 6 days, because coming events cast their shadows before. So preeclampsia, which is going to develop later in the second half of the second trimester or third trimester, is going to be picked up at 11 to 13 weeks, 6 days. How? With the help of biophysical and biochemical markers, right? So nuchal scan, 11 to 13 weeks, 6 days is a very good opportunity for all of us to try and predict preeclampsia with the help of these markers, which are biophysical markers, maternal demographic factors, mean arterial pressure, and uterine artery PI. Now, maternal factors more than 40 years of age, racial, certain races like Black, South Asian, body mass, BMI of more than 35, IVF conception, past history of diabetes, chronic hypertension, chronic renal diseases, APLA, SLE, family history of preeclampsia in mother or sister, previous history of preeclampsia, preterm delivery before 34 weeks, pregnancy interval of more than 10 years, and new partners. So these all factors are going to put the patient at high risk for preeclampsia. Second important biophysical factor is mean arterial pressure. Now, this is something which we all can do. As I said, we all know about everything about prediction, but what we need to concentrate upon is what all we can actually put into the practice, right? History you can always take. Mean arterial pressure is nothing great, right? Systolic BP plus 2 times diastolic BP upon 3, or there are some calculators available online also. You can calculate. But what is extremely important as far as mean arterial pressure is how do you measure it? So we have our conventional sphygmomanometer, which we have been using since years. But these days it has been seen that automated blood pressure allows simple, standardized, and repeated measurements which can be taken. So they have to be validated automated devices which are to be used with correct cuff size, with women in sitting position, with back supported, legs and cross. 2 measurements should be taken from each arm simultaneously, and with each arm supported at the level of heart, and that the average of 4 measurements should be taken. So this is how it has to be taken actually. I know with busy OPD it's extremely difficult, but then dedicated staff can be trained for this, and we can have a dedicated area, and all those who are doing nucleus can we always see to it that we take a proper blood pressure measurement as prescribed in the FMF based algorithm, and then only we take that blood pressure into account when we calculate the risk for preeclampsia. So as I again and again I say, we need to get sensitized to do things in proper way to calculate the risk effectively. Third important biophysical marker is uterine artery PI. Again, this is something very close to me because it is related to ultrasound. Again, learning to take uterine artery PI is not a rocket science, right? In the first trimester, when you are trying to learn about a good nucleus scan, you can always learn about uterine artery waveform. And in uterine artery PI, we always look at the MOMs. So here, as we can see, the technique of uterine artery Doppler is extremely easy. With set section of the uterus and cervical canal is obtained, and on either side we'll be able to see the uterine artery, the ascending branch of it, and the color flow Doppler. And then when we put the sampling gate of 2 millimeter on this ascending branch, will be with this angle of inclination less than 30. This is the kind of waveform that we are going to see. And then we look at the PI centiles. More than 95th centile is what is going to put the patient at higher risk for developing preeclampsia. So this is something which is showing a normal diastolic, good diastolic flow, and this is the one which is showing high uterine artery PI, which is going to put the patient at high risk for preeclampsia. So again, it's my request to all the obstetricians that we must now become sono obstetrician and try and learn doing things on our own so that we give better outcome to our patients, predict things early in the pregnancy. So a little more addition of information at 11 to 13 weeks, 6 days, like uterine artery PI is going to change the prediction and prevention of preeclampsia to a great extent. Now, though we are talking about first trimester markers, I would like to say that uterine artery PI is something which we also look at in the second trimester. Actually, the sensitivity and specificity of uterine artery PI is very high at second trimester. But because we want to predict and prevent, we look at uterine artery PI in the first trimester, which I'm going to discuss again later in my slides. So that was about biophysical markers. Now, which are the biochemical markers? So we know that there are 2 important markers as far as preeclampsia prediction is concerned. One is PAPE and another is PLGF at 11 to 13 weeks, 6 days. Now, PAPE is like insulin-like growth factor, and when it is less than 0.5 MOM, it can detect early preeclampsia fetal growth restriction, whereas PLGF is a more specific marker as far as preeclampsia prediction is concerned because it is an angiogenic factor, and therefore less than 0.5 mm of PLGF is going to predict the risk for preeclampsia. Now, whenever we take both these biochemical markers, less than 0.5 mm of PAPE and PLGF, they are not just markers of early onset preeclampsia, but they are actually markers of placental dysfunction. So which are these? Early preeclampsia, fetal growth restriction, abruptio placentae, stillbirth, preterm delivery. So these markers are going to give us a lot more information. I'm sure all of us Now, this is something which we have been talking about a lot in last at least 8 to 10 years. And this is what is proposed by Nicolaides to invert the pyramid of antenatal care. And in this, the prediction and prevention of preeclampsia and fetal growth restriction plays important role here, because previously, when I did my residency, the model that we had of antenatal care was like this, where we used to have very few visits in the first half of the pregnancy, then every 15 days after 13 days, and every weekly after 36 weeks. So more weightage was basically given on managing the complications once they occur in the last 10 weeks of pregnancy. Whereas the new model says that we should pay maximum attention to our 11 to 13 weeks, 6 days window, which is a golden window, not only to predict calculate the risk for aneuploidies or to find out the structural anomalies, but also to predict preeclampsia and fetal growth restriction and try and prevent it, or at least delay the occurrence of these dreaded complications rather than managing in the second trimester. So it is our responsibility as an obstetrician to see to it that all our patients get the maximum use of this window, and we can help these patients with biophysical and biochemical markers. Now, again, these biochemical markers are also affected by so many factors: gestational age, maternal weight, racial origin, smoking, IVF, nulliparity, pre-existing diabetes. And therefore, when we know that so many factors are affecting this biochemistry, it is extremely important when we are sending these samples to a lab, then it is extremely important for us to check that the lab is standard. Standard in the sense, a lab, sorry, just excuse me. A lab that does not ask for all this, you should never send your samples. Secondly, a lab should be the one where annual audit is being done, annual MOMs are calculated based on that, and then only that lab can be considered a standard lab. And so as we can see here, that when we combine these biophysical and biochemical markers, the biophysical markers, that is mean arterial pressure, uterine artery PI, increase in preeclampsia, whereas biochemical markers like PAPE and PLGF decrease, that is below 0.5 mmol. So this is a theoretical part of it. We now know that these markers are going to help us. Now, what do all recommendations tell us about these markers and which one we should be using in our day-to-day practice? So ACOG and NICE guidelines are something which we always look at. So in 2018, ACOG and NICE guidelines said that you should only do history-based prediction at first visit whenever a patient comes based on your demographic factors, obstetric and medical history. Whereas FMF UK said a combination of biophysical and biochemical markers are superior to other tests, and therefore we must use both of them. FMF UK has given its calculator. There is a training, you can take a training in this and you can calculate the risk, or else you can put the values in the calculator which is available online, in which you have to put in all the things that we have discussed about biophysical and biochemical markers, and at the end of it you can calculate the risk. FMF UK has done this biggest ever trial trying to predict preeclampsia with the use of all this. A spree trial was done, and that trial told us that when you use all these material characteristics, biophysical markers, biochemical markers, you'll be able to predict preeclampsia to the tune of 90% as far as early onset preeclampsia is concerned. Again, try and recall our the subgroups of early and late preeclampsia, right? Early onset is the one which is of major concern because of major severe complications. So if we can predict 90% of those early onset preeclampsia, well and good, right? The late onset, the prediction is not very good, maybe to the tune of 77%. Now, this is again a very, very important slide because it tells us about sensitivity of each marker for prediction of preeclampsia. So when you just take mean maternal demographic factors and mean arterial pressure, which is the least that can be done in our OPD, the sensitivity is 51%. When you add a sonographic marker, biophysical marker, uterine artery PI. Look at this. The sensitivity straight away increases to 75%. When you add PAPA to it, the sensitivity improves to 80%. When you add PLGF, a specific marker, sensitivity is 90%. So each addition of each marker will improve the sensitivity of prediction of preeclampsia. So now we come to the again comparison of NICE and FMF as far as prediction of preeclampsia is concerned. So the detection rate of preterm preeclampsia with the NICE only history-based prediction was just 40%, whereas with this was the result of SPRE study which was done by FMF UK, and based on FMF algorithm, where all the factors are combined, the detection rate is close to 80 to 90% for preterm preeclampsia. Now we have predicted, but are we here just to tell patient at 11 to 13 weeks, 6 days that look, you are at high risk for preeclampsia? What next? Patient will ask the question, okay, I'm at high risk. What can you do for me? Can you prevent this? So the answer is yes. Either we can prevent it, or if not prevent, we can delay this particular preeclampsia. And how do we do that? Here comes the aspirin story. So the aspirin, the doses of 50 to 150 has been used since 1980s, but it is the most abused and misused drugs, and it is unnecessary prescription has been given of aspirin in obstetrics. So benefits are clear, but there are very conflicting data. So how and when to predict, start the aspirin, and what is the base dose, and when to stop, and all that. So let's start with when and how to screen and what dose of aspirin. Again, ACOG and NICE mentions that at first visit, based on your history, you should, if the patient is high risk, then you give low dose aspirin, the dose of 81 from 12 weeks, at least before 16 weeks of pregnancy. FMF recommendation, again based on SPRE and Aspiratal, which are the most looked upon test as far as prediction prevention of preeclampsia, says that aspirin should be given based on the base algorithm at 11 to 13 with 6 days. Those who are high risk, that is more than 1 in 100, based on your biophysical and biochemical marker, when you put in the calculator and the risk comes maybe 1 in 90 or 60, then these are the high risk patients. And in those patients, you start with aspirin 150 milligram and not 80 or 75 milligram. And with this dose, the reduction in early onset preeclampsia was seen to the tune of 90% before 32 weeks, and less than 34 weeks, almost 82. So 80 to 90% is what we see as prevention of preeclampsia with 150 milligrams. So we all know that it is the right dose, that is 150 milligram and not 75 milligram. Now, such comprehensive screening, can we all do all this biophysical, biochemical all across India? No, it's a dream. But we know that it is strongly evidence-based. So we need to produce a robust data on our obstetric population. Now, when you try to compare, we know that some people may start screening at early first visit, and that is not going to be very inefficient. But when we use this screening program at 11 to 13 weeks, 6 days, including all biophysical biochemical markers, they are more powerful screening tools in the terms of sensitivity that we have seen just now, and therefore could prevent more early preeclampsia and fetal growth restriction. Now, when to start and stop aspirin? Again, duration, as FMF UK mentioned, before the second wave of trophoblastic invasion. We do not want that insult to occur already, right? So we want to start it before 16 weeks. So at 11 to 13 weeks, 6 days, if it is high risk, we start so that we get that improvement in spiral artery waveform. And it has to be continued till 36 weeks of pregnancy. Again, ACOG is at least in agreement with this, because that also believes that before 16 weeks, it should be started. So with this comparison of FMF and ACOG studies and all, have all questions been answered? Well, not really, because picture abhi baki hai mere dost. Here comes the main hero, and that is FIGO, right? That is above all the guidelines of NICE and ACOG and FMF also. So what did FIGO do? So FIGO, as a sneak peek at aspirin in pregnancy, it took into consideration 21 systematic reviews since 1991 and tried to find out what is the correct dose, whether it should be given in 80, 75, 150 watt. So it has taken, FIGO has taken into consideration the ESPRESS study, or the SPREE study and ESPRESS study of done by FMF UK. And it showed that when you just take history and mean artery pressure, the detection rate would be 60% only. Only history is just 47%. When you add mean artery pressure, 60%. And when you take all markers, biophysical, biochemical, close to 88%. So FIGO also mentions that we have to take into consideration all the markers. So based on all these studies, it tried to find out why the lower dose is not working actually. So they tried to look at the aspirin resistance, and that they found that in entire population, 29 to 36% patients are resistant to aspirin when it is given the dose of 81 milligram, right? And this is what again from the FIGO site itself showed that when you give it in the dose, aspirin is given the dose of 81 milligram, the resistance is 30%. As compared to that, when it is given in the 160 milligram, the resistance is 5%. So remember one thing, when you're giving your 150 milligram aspirin, the resistance to aspirin is going to be just 5%. So that is the right dose, which is going to help our patient. So these are the recommendation by FIGO on 22nd May 2019 that the risk calculation should not only be clinical history based, but you should also use biomarkers. It has to be a universal screening for all at first trimester, and it should be a one-step procedure. And based on biophysical biochemical marker, that is the best combined test for preeclampsia. When the high risk is more than 1 in 100, then you should offer. The calculator is also available on the same calculator is available on FIGO site also. If you go, you can put in your values and calculate the risk and then start your 150 milligram of aspirin based on this. Now, FIGO also mentions that we know that everywhere it is not possible to use the best combined test. So when there is low resource setting, then at least use history plus mean artery pressure. Mean artery pressure is not something which is very great. Everybody, even in the remotest area of India, mean artery pressure can be combined with the risk factors to improve the sensitivity of risk calculation. But it should not be just based on risk factors. That is one thing. Second thing, screening performance will be reduced when screening does not include all elements. That also FIGO mentions. And prophylaxis, when the risk is more than 1 in 100, should be started in the dose of 150 milligram at night till from 11 to 13 weeks till 36 weeks. And please do not prescribe low dose aspirin for all women. Also, FIGO mentions about the dose of calcium, that usually if there is low calcium intake, a calcium supplement of 1.5 to 2 gram elemental calcium is going to help these patients. And again, in multiple pregnancy also can use the combined algorithm. However, the screen positive rate is high. So when we understand about the do's, we should also understand about the don'ts, and that is, do not prescribe low dose aspirin for all. Do not use maternal risk factor alone. At least use mean artery pressure and uterine artery PI. I am sure everybody is getting at least nuchal scan done at 11 to 13 weeks. Scans in majority of the rural areas of India as well. So you should just either do it yourself or tell your sonologist to do uterine artery PI. So now when we know that aspirin is the drug, then we should know everything about it. How does it act? So in the low dose, that is in the dose of 150 milligram, it is COX-1 inhibitor. It reduces thromboxane A2 and therefore it reduces platelet activation. Now, some of the common side effects that we thought of, like vasoconstriction of both ductus arteriosus and renal artery, is seen only with very high dose, which is used either for headache or rheumatoid arthritis, which is used in the dose of maybe 500 to 1.5 gram per day, which we are not using. So we are not going to see these side effects and closure of the ductus arteriosus, renal artery, which is not going to be seen with the dose of 150 milligram. Contraindication, are there any? The absolute will be allergy to aspirin, gastric ulcer or severe gastritis, asthma, and hepatic dysfunction. Rest all patients we can safely give aspirin. Even WHO mentions about use of calcium. Now, this very important information which is coming out of WHO is which calcium to use. Now, it says that 1 gram of elemental calcium equals to 2.5 gram of calcium carbonate or 4 gram of calcium citrate, which we are using these days commonly. But calcium carbonate is cheaper and just 2.5 gram is required for 1 gram. Again, in rural area, we can give calcium carbonate because that's going to give us a good elemental calcium. So as I said, we are also going to throw some light on newer insights. Are there any other markers for preeclampsia, especially in the early pregnancy? So, well, as we know, NIPT is something which we are using for our aneuploidy screening as a secondary screening test. So when it is a non-invasive test and it's a very simple test, maternal blood is to be used, why not make use of it for preeclampsia prediction? So this is something, again, experimental, but has its own future, and maybe in the future we'll have data coming out for prediction of preeclampsia, because we know that apoptosis at the level of placenta is going to be high, and therefore there will be increased cell-free fetal DNA quantification in your NIPT or cell-free DNA test, which is done at 11 to 13 weeks, 6 days. Another marker is reduced index of placental vascularization, 3D Doppler at 11 to 13 weeks, 6 days. Again, very, very experimental at present, but maybe in future we'll have some of these markers, added markers to predict preeclampsia. So this was about predicting preeclampsia. But are we just looking at predicting preeclampsia and try and prevent or delay it? Well, we also want to, we know that despite all these, there are going to be still many cases of preeclampsia, and dreaded complications are still going to be seen sooner or later in pregnancy. So can we prognosticate or predict the maternal complications? Well, yes, it is not in the first trimester, but yes, when we have, so I would just like to throw some light on this, and that is S-fleet and PLGF ratio. We know that S-fleet is anti-angiogenic, whereas PLGF is angiogenic, and therefore a high ratio is suggestive of impending placental dysfunction. So this very good study of prognosis said that when the ratio of S-fleet to PLGF is less than 38, majority of women will not develop preeclampsia, at least in the coming 1 week. But if it is more than 85 or 110 in case of late onset preeclampsia, these are the females who are very likely to develop severe complications of placental insufficiency like fetal growth restrictions, stillbirth, or even HELLP syndrome. So isn't it a good information which is coming out? Yes, it's an expensive test, not available everywhere, but I am sure in future the rates are still going to come down, and I think we'll be able to make use of it to improve maternal and perinatal outcome. When the ratio is between 38 to 85, these women do not have a definite diagnosis, but they are highly likely to develop preeclampsia within 4 weeks. So again, a very good information coming out of this important marker. And are there any other markers for predicting, the prognosis or complications, maternal complications? These are two new things. One is Congo red dot paper test, and one is ophthalmic artery Doppler, both in experimental phase. So this Congo red dot paper test is performed on fresh urine samples of mothers, and the proteins in the urine of women with preeclampsia bind with this Congo red dye, which is known as urine congophilia. This test has good 80 to 90% sensitivity and specificity. Now, why is this an important test? Because maybe in a busy OPD or in a maybe government setup or a big corporate setup where a lot of patients are there, this is a simple and non-invasive test, and this is how it looks like. A schematic present, this is negative, and when the more and more proteins are binding with this Congo red, it will evenly spread on this. So this is showing a high risk for developing preeclampsia complications in the mother. So how is it useful practically? It has potential to cut the need for triage referrals, decrease the turnaround time for diagnosis, shortens the length of strain obstetric triage. Suppose one patient is admitted and you want of preeclampsia, and you want to know patient is improving, and you want to know whether you can you need to keep this patient admitted or you can discharge, then this kind of simple test may help you and eliminates unnecessary hospital admissions, and can also be used in patients with non-specific headaches where you are in dilemma whether it's really preeclampsia or not, whether there's proteinuria or not. This is going to help us. Again, ophthalmic artery Doppler is something which is very new, recent concept, and we'll see more studies on this in future. But here again, when we look at, this is done basically again to try and predict the complications at around 35 to 37 weeks. This is done, and we look at the second peak of first and second peak of systolic velocity, and the ratio is taken, and in the ratio, PSV ratio is more than 0.99. Again, it predicts more possibility of maternal complication. Again, these are all in experimental basis, but I thought of sharing it with you because I'm sure in future they are going to be useful days for all of us. So as far as carry-home message is concerned for predict and prevention of preeclampsia, well, as it is said, do the best you can until you know better. Then when you know better, do better, because I'm sure more and more screening tools are going to come in future, and we'll know which one is better and more available, more cost effective, which can be used all throughout our nation. So we aim at the best, but something is better than nothing. And this is my favorite slide because it tells us that when we have all markers, when we can use, the sensitivity is 9%, but least possible that we can do, we are doing nucleus scan with double marker. PEPE is a part of it. The sensitivity of preeclampsia is to the tune of 80% with that. And even if patient is not ready for double marker, at least do uterine artery PI with your nucleus scan either on your own or tell your sonologist to do, so that you get at least sensitivity of 75%, which is least expensive and yet so informative. So we are no more aiming our arrow in dark, and we know which specific patients to start low dose aspirin. So as far as role of low dose aspirin is concerned, we all are wise enough to decide what dose based on evidence-based medicine, that is 150 milligram. And how good are we? Well, we are reasonably good in predicting preeclampsia. Only thing is we have to use the correct combination of markers depending upon availability and cost factors, and of course the sonologist. And with all this, we're capable of preventing especially early preeclampsia to the tune of 80 to 90%. We are going to see lesser and lesser severe preeclampsia, eclampsia, HELLP syndrome, renal failure. Isn't that a good news? So let's all of us get more sensitized to use the simple tools which are all available to us. We just need to use them at the right time and start the right dose of 150 milligram aspirin and try and prevent or delay this complication. And with this slide, I would like to conclude that as a chairperson for the Imaging Science Committee, it is my dream to see that every obstetrician becomes a sono-obstetrician or gynecologist, and then only we'll be able to help all our patients. So with this, I conclude my talk, and I thank you all for patient hearing. Thank you so much.
Thank you so much, ma'am. Now I would request Dr. Seetha, ma'am, to give her concluding remarks.
Thank you, Bela. That was an excellent talk as usual, very comprehensive, and you said exhaustive, but you managed to cover everything because it is a vast topic. I know we all deal with it every day, day in and out. So I really don't have much to add, but I just would say that as we all screen for aneuploidy, we tend to forget that preeclampsia is such a burning problem, and a lot of people go undetected, and a lot of complications can be avoided. So, the algorithm that she gave is excellent, but even in the remotest of places, even if you don't have the facilities, you can do a basic history taking and use our Foxy gestosis score, which is there. And in those people who are deemed high risk, you can send them to other centers where they can have the mean arterial pressure and the uterine artery PI and detect if they need further dose of aspirin. That's one. So that gestosis score is also easily available. And the second bit is a lot of our patients already come on a 75 milligram of aspirin, though she rightly said it shouldn't be used as a panacea for all prevention disorders. But a lot of our IVF patients already come on a 75 milligram dose of aspirin, and you can't can't really stop them because they have been on it. So again, if you screen them, it is important to understand and realize whether they need another extra 75 dose of milligram of aspirin to prevent the dreaded complication of early onset preeclampsia. So these two would be the scenarios where we would, face to our day-to-day situation. And the rest, thank you once again for an excellent talk. Thank you, Bela.
Thank you.
And Dr. Sujit, if you want to add something more on this, please.
One question is quite often asked regarding this uterine artery Doppler and aspirin. We start aspirin when the uterine artery PI is more than 95th centile. Suppose there are some cases where in first trimester uterine artery PI is normal, and suppose at around 28-30 weeks it is going beyond 95th centile.
At what weeks?
At 28-30 weeks.
Then it is not going to help. Then aspirin is not going to help at 28 weeks. The damage has already occurred. So then
yeah, true. But aspirin is definitely not going to help. But if the PI is high, this means that this baby is at risk of developing problems later on, or the mother can develop preeclampsia. That only gives a prediction. We can't prevent it then. Uterine artery PI has its role in the mid trimesters and late trimesters. It can predict that this mother might have preeclampsia problems, but it's too late to start aspirin or do anything.
It predicts not just preeclampsia, but chance of fetal growth restriction also. So we monitor these fetuses very closely with growth as well as Doppler and try and kind of monitor them well.
Thank you. Yes.
Ma'am, we also have one. Okay. Yes, ma'am.
Dr. Bela, very nice lecture. Very nice and informative lecture.
Bela, can you read the question from question answer? It says, is there any difference in uterine artery PI measured transvaginally and transabdominally?
So usually, routinely, we always check uterine artery PI transabdominally. It is very well, we can measure. Transvaginally, the PIs are likely to be little on higher side. And we usually do not measure unless until it's really, really difficult, which is practically not seen. We can always take it transabdominally. And all
better to have it
abdominally.
Sorry?
Yeah.
Better to have abdominally.
Yes.
Yeah. Thank you.
Dr. Veena is also here. Madam, you want to say something?
Welcome. A very nice informative talk. I just wanted to know, sometimes patients come to us from tertiary area, from very long towns far away from the city center. And sometimes if they come to us at around, like Dr. Sujit said, at around 28-30 weeks, early onset FGR is already set in. Do you feel there is a role of starting heparin now?
No. So
sometimes I have it subjectively, no harm, but sometimes benefit also.
So the thing is, the only indication of low molecular weight heparin is when there is APLA positive, screen positive patient. Rest, empirically, the role of heparin is not there and it is not found to be beneficial and it should not be used.
Okay.
Only APLA positive, screen positive patients will use.
But it's very difficult to get APLA positive, madam.
And that's what, so already that's what, at 28 to 30 weeks, this is not justified to start low molecular weight heparin. It's better, see, then what we have in our hand is monitor them well with Doppler and try and decide the timing of delivery so that we can give the best perinatal outcome to this fetus. That is, that will be our role.
Okay, sure. Thank you. I think Dr. P.K. Shah will tell us how to use Doppler to deliver such babies. Thank you, Dr. Bela again.
Thank you so much.
P.K. sir, your comment, please. Sir, you are muted.
Sir, you are muted.
You're muted, sir.
Bela covered everything so beautifully.
Thank you, sir.
What is important is, like Dr. Veena Panath said, some of the obstetricians do use heparin and even aspirin after 16th week of gestation. Let us make it one thing very clear that once the damage is done to the uterus, the placental vessels, it cannot be reversed. So there is no point in giving aspirin, heparin, etc. In a given situation, you can have a good obstetric outcome, but you can't put 2 and 2 together to say that yes, because I started aspirin late, because I gave heparin, I had better results. No, definitely not, because it has been proved beyond doubt by so many papers that aspirin, if at all you want to start, you should start it before 16th week of gestation. That is very clear now, and it is accepted world over, and 150 milligrams. So I think this message has to go very clearly to each and every obstetrician who is practicing in our country.
Just one comment I would like to make here, that yeah, sometimes it happens so that patient has missed first trimester scan. Patient comes directly in the second trimester, maybe around 18 weeks, and the uterine artery PI is high, and along with all biophysical markers, when you put in, you feel this is a high risk patient. Now here, as theoretically we know that the second way of trophoblastic invasion is from 16 to 21 weeks, but it may prolong till 23 weeks. So we can give benefit of doubt just by giving aspirin in this a small subset of patient, just to give benefit of doubt, whatever little help it can do. But then you have to counsel the patient that the best time is before 16 weeks, but till 21, at the time of anomaly scan, some benefit, just to give benefit of doubt, we can start, because whatever
in our practice, all of us do so many things,
yes,
which cannot be written down on papers.
Yes,
but that does not mean
no.
That should be the
ideal time is
that should be the rule.
No, it is
so
not.
When you talk from a platform for general gynecologists, I think you have to give a very clear-cut message. Then what they do in their practice, you have no control. You cannot supervise them. So things are happening, as you very rightly said. Even we all have done. We have been giving so many things. Now, one more thing that has come very clearly is calcium. We used to give homeopathic dose of calcium, 500 milligram, 1000 milligram, and all that, 1 BD. Like 2000 milligram is the minimum that you can give once a day. And the best way you can deliver to a woman on whom you cannot rely on is to give 60,000 international units every month after third month, after first trimester. Give every month whenever you feel there is vitamin D deficiency, or even otherwise. So that is the best way you deliver vitamin D3 to a patient, 2000 international units per day. There are very clear-cut messages now given, and we are happy that we get all these things ready-made to follow. We don't have to do all this analysis and research and all. We get all these things ready-made. Only thing, we have to follow them religiously.
Very true.
Chalo, let's go to Ajay.
Thank you, sir. Thank you so much for your comments. As our next guest, next speaker, we have Dr. Ajay Mane, who will be talking on medico-legal aspects of USG in pregnancy. Dr. Ajay Mane is contesting for post of VP Foxy West Zone. So we wish you all the very best for your forthcoming elections in Foxy, sir. Over to you, sir.
Thank you, Karishma. And with the blessings of PK Shah, sir, Sita ma'am, and my friends Bela, Sujit, Archana, Veena, and the blessings from my mentor, Dr. Rajendra Singh, sir. Can I share my screen? Hello? Hello?
Dr. Stalin, you can stop sharing.
Yes, ma'am.
Chitrakala? Yes.
Yes.
Dr. Gorakh Mandrupkar joined as a delegate. Kindly promote him as a faculty. Okay?
Yes, sir. Yes, sir.
Yeah. Yes, is it seen? Hello?
Yes, sir. Yes, sir.
Yes,
Yes,
thank you. My gratitude to Dr. PK Shah, sir, who is the Bhishma Pitama of sonography in field of gynecology. Dr. Prashant Acharya, sir, very good friend of all of us. And Dr. Rajendra Singh, sir, my mentor. Gratitude to Dr. Yashwant Gade, sir, MMC observer, my teacher, Dr. Sadanand Ingre, president, and Dr. Vinod Rajankar, secretary of Buldana Observation Society. Then chairpersons, Dr. Sita ma'am, and Dr. Sujit Konkar and Dr. Veena Panat, both are my class fellows. Then co-speakers, Dr. Shah sir. I'm fortunate enough to share the dais with Shah sir. Then Dr. Bela Bhatt, our good friend. Then Archana Patil, and all delegates, and particularly Dr. Shield Healthcare, Dr. Stalin, and Chitrakala for the help. So directly we are moving to the cases. Is ultrasound necessary before doing MTP? By my opinion, it is mandatory, but by law, it is not mandatory. Why my opinion is like that? Because in Ministry of Health and Family Welfare advisory book, they have given in general physical system, abdominal and pelvic examination, rule out ectopic pregnancy. How to rule out? Clinically, we can know that the cervical movements, tenderness, or the fornicis tenderness, if the tube is stretched, then and then only it is tender. If it is in early phase, it is not stretched, then it is not tender. What can be remedy? Ectopic pregnancy can be diagnosed with a careful history, examination, and USG. They have given the book. So, and with the stalwarts like all of you, you can diagnose the pregnancy. If it is an intrauterine, if it is extrauterine or heterotopic, maybe it is there. And second thing, it tells about the gestational age, which is very mandatory in the era of MTP Act, because if you are having first trimester MTP center and maybe it is proved that it is 12 weeks or 13 weeks on borderline cases, then you are at problem. So kindly have a proper gestation. Now we move on to direct cases. We are not interested in name. All National Redressal Council cases. Antenatal USG findings. USG was done on 21 by Dr. Saluja. 20 weeks and 6 days gestational age with no abnormal findings. The fetal spine, trunk and limbs are normal. This is the report given by the doctor on 21/2009. Okay. On the basis of said report, Dr. Indira Vyas, who is a gynecologist, continued the pregnancy at 32 weeks of pregnancy. On 22/4/2009, another USG was performed by another Dr. Soni and reported as 32 weeks, 1 day plus 2 weeks, severe oligohydramnia. That was first adverse remarks given, and the fetal spine, trunk, and limbs are normal. Okay, this was the report given by the second radiologist, rather sonologist. But unfortunately, on 18/5/2009, patient delivered a female baby, which was found not fully developed. Newborn's left arm and kidney were missing, and even lungs were not completely developed. The fetal weight was 1500 grams only instead of 2500 grams. Thus, they alleged it was medical incompetence and gross medical negligence. So, court result was sum of 15 lakh rupees fine to be paid to the patient with a 12% of the interest in 2009. So, it will, if it would have been today's era, it would have gone about near crores. So be accurate in your results and the words, because invariably we copy paste the result and change accordingly. But if you forget to change some sentences, it may go like that: all trunk limbs are normal, and it is abnormal. Okay. The story of that case was when the doctor called in the court, they said, no, sir, the patient was referred to have only a finding of gestational age. That's why we have seen only gestational age and given the report. We have not seen the limbs. Then the court asked, if you have not seen the limbs, why you have given the result about the limbs? All limbs are normal. So we have not seen. The second sonologist say, no, the position was not correct. So you should have called it then after a few days or after maybe a few hours. And when the baby changes his position or her position, then at that time you should have done it. Usually we do that, no? If you could not get the proper view, we'll make the patient sit or maybe come after 2-3 hours. And when the baby changes the position, we can. And one more tip from my side: those things which you have seen should be written on the paper, and the things which have not seen or appreciated should be written particularly on the paper. These things are not appreciated or not seen. Advised patient to come maybe today, after 2 days, after 1 day, for the appreciation of these things. If you write this, you are free from the litigation of negligence. Okay. Second, patient conceived in September 11, USG done on 11/12 only, and the reports were baby is normal. No fetal parameters were explained on the paper. What is the report? Baby is normal. That's all. Some of the gynecologists or obstetricians, they are having a habit of putting the probe on the abdomen when patient come for the routine ANC follow-up. They make on the paper and the machine put the, okay, everything seems to be fine. Put the probe back, write it down on the paper, one line, baby is fine, or everything is okay. See, on 31/5/12, it was reported everything is okay. What is this report? This is a very wrong thing. I request you to kindly give the report if you are giving it in writing form. And if you are putting a probe on the pregnant woman's abdomen, you need to follow all the protocols of PCP. Then and then only start the machine. Otherwise, don't use the machine. Use your clinical knowledge. This is my request. Okay, fine. Then USG done on 7/6/12. Baby was deformed, malformed for 4 limbs. There was a poor visualization due to absence of amniotic. This third finding. 2 were normal. Baby delivered by cesarean section. And again, court seen it is faulty or the negligence on the part of the doctor, 10 lakh compensation. Okay, fine. Case number 3. So these are the negligence on our part. We are not interested in getting USG allegation. In anomaly scan, sonologist missed limb reduction deformity. The fetus had only a stump below the elbow without any forearm. Court result, 5 lakh fine. Okay. Then case 4, a case of ectopic pregnancy. That's why I told sonography is very important. On 5/5/97, a complainant suspect pregnancy and consulted Shobha Chakrabarti. Then the UPT was positive. Ultrasound was conducted in Advanced Diagnostic Center, Ranchi. Okay, working. And given no evidence of any focal lesion or gestation sac is seen. Both ovaries are normal in size and shows normal. Uterus is actually retroverted and retroflex, shows normal size in endometrial liposuction. No evidence of any focal lesion or gestational sac. So UPT positive, but the uterus is empty. There is nothing in the parametrium also. But unfortunately, the patient was admitted with a shock, and there was a procedure which is removal of horn of fallopian tube, resulting to permanently incapacitating her for becoming pregnant. So they have alleged for 4.75 lakhs compensation. But the reports were put in the court, the books were put in the court, the protocols were put in the board and court, and what can be missed is very well explained by the doctors and the advocates from the doctors, and doctor is not found guilty because the it was ischemic lesion and this can be missed. It is given in the books. So the court considered conclusion, proper reporting, giving proper references in court, and record keeping saved their doctor. This is the only case. Very rarely doctors are saved, but this is one of the rare cases where we have saved. Umesh Kumar versus state of okay, we are not interested in. Gudiya Kumari went to Bishwas Seva Sadan for treatment as she was complaining of pain. She was pregnant of 2 months. Okay, then the doctor who was there was I think some Vichitra person. He advised DNC procedure for cleaning the womb to stop the pain. On refusal by the father of the daughter, the doctor Bishwas Seva Sadan insisted upon that it should be done. So insisting and having the consent is not a proper consent, because in consent it says it must be a voluntary consent. If it is insisted or if it is by force, it is not a valid consent. So he has taken the consent by insisting and took the patient inside, have DNC without sonography, and unfortunately the patient died on the table and brought out of the operation theater dead. So body went to postmortem, no external findings overhead, dead, neck, everything was fine. Abdomen finding, the abdomen was open, peritoneal cavity was filled with blood, left fallopian tube was ruptured at the junction of 2/3 and 1/3, tube was thickened, uterus was empty, means it was an ectopic pregnancy, urinary bladder was empty. In my opinion, the postmortem report says the cause of death was hemorrhage and shock caused by rupture ectopic pregnancy and anemia. Most probably duration was within 16 to 18 hours since postmortem report. If he would have done the sonography, he would have come to a conclusion that it is a ectopic pregnancy. He would not have done that DNC or DNE. What procedure he had done in the operation theater, we don't know, but the patient died. And what was the court result? Doctor was found guilty as negligent and punished. Why punished? Because it becomes a criminal negligence. If it is a civil small negligence, it becomes a civil negligence. You need to compensate. You need to pay the compensation. If it is a very gross negligence, it becomes a criminal negligence. And along with the fine, you may get the imprisonment, maybe rigorous or a simple one. Sonography is necessary before doing MTP and DNC. Yes, fine. Chronic abdominal pain on a 16-year-old unmarried girl. 16 years, okay, before the era of POXO Act. A 16-year-old unmarried girl went to a gynecologist for chronic abdominal pain, referred to a radiologist for sonography. Routine case, radiologist done USG, there was a sign of 16 weeks viable, normal pregnancy. No, it is of after POXO Act. And he referred back to the gynecologist again. Gynecologist referred this case to civil hospital, government hospital for further management. This is the case scenario. 16-year-old unmarried girl found pregnant, and the sonologist sent her back to the doctor. Doctor sent to the civil surgeon. Did gynecologist give right treatment and advice? And did radiologist did his job properly? No, because it comes under POXO Act. court summoned both gynecologists and radiologists by asking why they have not informed the police, because it is mandatory to inform the police under POXO Act. POXO, not POSCO, it is POXO, Protection of Child from Sexual Offences, 2012, amended in 2019. It is the act where we are bound to inform the police if the patient or the girl found pregnant if less than 18 years completed, not started 18, completed 18 years. We need to inform the police in writing and have a receipt from the police, because afterwards anybody can deny that doctor has not informed. So have a writing receipt from the police to your record. So it is a protocol. And if you not inform, is a punishment given in the amendment, that 6 months imprisonment. That is the more dangerous situation. A case of adnexal mass in a 15-year-old unmarried girl. An unmarried girl of 15 years, and in POXO Act, married, unmarried do not make any difference. If she is less than 18 years, you need to inform, though married or though unmarried. Okay, that is the tip. An unmarried girl of 15 years, complaints of abdominal pain since 3 months, not related with conservative treatment. USG was sign of right adnexal mass 2 by 2 centimeter. Obviously, right adnexal McBurney's point means appendicular mass. Everybody considers that. Operated by a surgeon and had a adnexal mass with adhesions. So remove all adhesions, sent for histopathology mention. Report received after 2 days after discharge. Patient discharged fine, and report sign of chronic ectopic pregnancy. So what are the duties of doctor in this situation? Again, POXO Act, that surgeon need to inform the police, and the gynecologist also need to inform the police. Whosoever first diagnose the pregnancy below 18 years must inform the police, is the provision given. Case 18. Fetal rupture of ectopic pregnancy, a case report. A 26-year-old unmarried female with a history of acute abdominal pain and bleeding per vaginum was brought unresponsive to the hospital. She was in shock on arrival and could not be resuscitated. Unfortunately died. Death was registered as a medico-legal case. Further investigations by the police revealed that she had amenorrhea of 8 weeks and UTI positive, which was not given history in the hospital. She had consumed abortion pills purchased from a local pharmacist without consulting a doctor. It is a crime on the part of that pharmacist. Without prescription, you cannot sell the MTP pills. And had a developed acute abdominal pain after 48 hours. Autopsy revealed a ruptured ectopic pregnancy. Must have given by some quack or directly that pharmacist. So it is a crime on the pharmacist part. It should not be done. So transvaginal ultrasound should be performed in suspected cases. These are the statistics I am not going to give you. And so what are the conclusions? USG tells us about pregnancy is intrauterine or extrauterine or heterotopic. Gestation sac also told by sonography for follow-up, for MTP also, and induction of labor. Fetal structure deformities can be very well diagnosed nowadays, 2D, 3D, 4D, 5D. Once upon a time, it will come that maybe we can take out the baby through sonography out and see and put it back again. Then it tells about the Leica around, quantity and characteristic, the quality also. It tells about the pelvic and fetal head measurements for the chances of normal labor, obstructed labor, whatnot. Then it tells about the placental position and structure, the PI and all the things you tell about that. It tells about the cord, everything. So accordingly, we can plan and be prepared for the forthcoming situations as anticipated well in advance, and can avoid mishap in patients and in our life too. This is very important. Nobody wants any complication in our hospital. Ultrasound is mandatory by my opinion before doing or even medical method of abortion also, because it is available up to 9 weeks in clinics where the MTP center is not registered, and you are having a backup certificate from a registered MTP center. 9 weeks Mizomifo we can give. There also we must have, rather my opinion, we must have a basic ultrasound which tells. And yet I'm not going to take home messages. Write those things which you could see and interpret in a sonography report. The report must be very careful. Mention the portion which was not appreciated well or not at all in reports. If you do not write anything, it is considered that you have seen that. The law says, if you are not mentioned and the report is everything is fine, means you have seen everything and it is fine. So if it is not seen, mention it. It is not seen or not appreciated, come again. Follow-up time and or the date of the repeat USG, if needed for revision of the USG, shall be given in report itself. So orally it is not. अरे मैंने तो पेशेंट को बोला था 2 दिन के बाद में. No, not accepted. Write it down. Write it down. Whatever you write it down is only considered in the law. Do not copy paste reports of previous patients. On lighter note, I have seen prostate in females too. When I was superintendent in medical colleges, there were reports from radiology department. No, there are 100 patients daily. So copy paste, and few of the patient having prostate in females too. So on lighter note, you may take as a copy of previous patient to next patient, but change accordingly and read it word to word before printing. Okay, you can make the changes and read it word to word. Or the better option is that you have a prepared report and ask somebody to read that, a third person, because he or she may find the mistake very easily. Check again before giving it to the patient. Print out, check again, read it carefully. Maybe 2 patients are less, but you check the report. You need to follow all PCP rules and regulations in pregnant women. If you are starting the machine, you need to follow that. Keep separate register for non-pregnant patients. This is again instruction from PCP wing. Then keep 1 copy of report with you, maybe a soft copy, but for PCP it must be a printout with the film on paper, and it should be attached with the referral sheet and kept in the record with the number 23/2022 likewise. Okay, get your data transferred to safe gadgets to secure it from virus and to avoid files from getting corrupt. Maybe at 2 places you can need it, and if needed, I pray to God that nobody will need this, mine and Hitesh and Gitesh sir's help, but we are always there in a phone call away from for any kind of medical legal help and advice. This is my phone number and email ID. It is completely free of cost. Kindly call me at any moment. Women Empowerment at Israel for herself, Women Empowerment in India for the nation, and Stato for the unit. Salute to this woman and army. And this is my humble request to you. Kindly vote for me for post of Vice President West Zone. There are 2 posts. Kindly vote for me for the 1 post. Second is your choice. And the voting starts on 21st of this month to 30th of the March. Kindly vote for me. Thank you very much, and thank you again for the quiet listening. Over to you, chairpersons.
Thank you so much, sir. I would request Kanat madam to give her concluding remarks on the talk.
Wonderful lecture as usual, Dr. Ajay. Ajay, you have become an expert in medico-legal issues, and as we cover other issues like the tubectomies and medico-legal issues, MTP and medico-legal issues, today we have covered this topic in a very nice, informative and exhausting manner. And just to add, and not to add, but to just again reinforce that whatever you see, whatever you talk to the patient, please document it, please put it on paper, because unless you put it on paper, it will be taken as a you have not screened that patient properly, you have not counseled the patient properly, and take their signature also that they have understood whatever you have told them and whatever you have counseled them, whatever you have given to the patient. Thank you again, Ajay, and our best wishes to you. And you don't have to say kindly. I know you are going to get maximum votes from all over India, not just Maharashtra. So best wishes again.
Thank you, Veena. Sita ma'am.
Thank you so much, ma'am.
Yes, I echo Dr. Veena's words. It was an excellent talk, and it's such a reassurance and relief for all of obstetricians and sonologists when we hear you talk. In the sense that if anything goes wrong, we can always call you. But of course, we don't want those things to happen. And in fact, this reminds me of the landmark judgment we had in Calcutta last month, when the spina bifida case was diagnosed in late 2nd trimester, and the High Court gave the permission for the woman to terminate at 35 weeks. That's a different story altogether. But yes, there is, and a very important thing to learn is to not to blame other doctors when we are counseling or talking about, patients. Very important.
Yes.
So Dr. Mane, best wishes, and I'm sure you will come as a great winner. And our wishes always with you. So best of luck for the upcoming elections.
Thank you, madam. Thank you very much. And nowadays we are having in amendment, they have mentioned that after 24 weeks, if you need to undergo the MTP, then we need a medical board opinion. We need not go for the High Court and the others.
Actually, this doesn't need a medical board, but that's a different debate. So I'm not bringing that.
Medical board was not there. That's why they have got
exactly.
the board.
High Court. Yes. Thank you.
Medical board is to be formed at some places. Thank you, madam. Thank you very much. Over to you, Karishma.
Thank you so much, everyone.
Thank you, Veena.
We would like to hear a few words from Sujit sir on this talk. Sujit sir, are you there?
No, he
I
must have
think,
gone.
I think he left between. I think he may have an emergency.
Emergency. He had left.
Okay. Moving on, I would like to request Dr. Ajay Mane sir to invite and introduce Dr. P.K. Shah for next talk, please. Over to you, Mane sir.
Yes, the great personality again from the field of sonography in gynecologist. I
Already
request P.K.
introduced.
Shah sir. Yes, sir. I request you to kindly proceed with your lecture. We are eager to hear that.
Yes, eagerly waiting for your talk, sir.
I think before I start,
I finished my talk before you, because once you talk, nobody will be there to hear me. That's why I have kept my talk prior to your talk.
people are afraid of medico-legal things. They really are interested in all medico-legal things that are being talked about. But before I start my talk, let me tell you, Ajay, that there was a case going on a gynecologist for doing 32 ultrasounds in second half of pregnancy. How many? 32 ultrasounds in the case of IUGF. So I think too much is also equally dangerous. To try and avoid as far as possible unnecessary ultrasound. So let me begin with.
Is there any known complication or side effect of ultrasound overexposure?
No, not the black and white, the one that we use. Definitely not. Definitely not. But it's a number of times, and the worst thing was every time the patient was charged. See, if you do ultrasound for your help as an obstetrician, it's a different situation. You should not charge the patient. But when you do 32 times ultrasound on a patient of IUGR and you keep charging her every time, I'm sure somebody is bound to complain.
Obviously.
So let me begin with my talk. On the top is a color Doppler in third trimester, how to monitor when to deliver. And I'm going to restrict my talk only to growth restriction for a simple reason, is that there are lots of problems that our gynecologists face in clinical situations they face in case of IUGR. I hope I give them a clear message so that they can follow it religiously. Fetal growth is a result of the maternal availability of nutrients, placental transfer to fetus, and fetus's own growth potential. And the fetal growth restriction in fetus doesn't succeed to reach its growth potential. Now, in order to exclude healthy small babies, severe fetal growth restriction includes all fetuses with an estimated fetal weight under third percentile that are associated with an increased mortality and morbidity. I'm sure all of you know very well the pathophysiology. It has already been told to you by Dr. Bela very nicely. There's a failure on the part of a trophoblast to invade spiral vessels up to 22, 23 weeks of gestation will lead to placental causes. And there is a sequence that there is an inadequate trophoblastic invasion, absence of uterine vasodilatation, reduced placental perfusion, hampered venous microcirculation, which will lead to umbilical hypoxemia and the vascular changes for compensation that we all know about. Now, growth related, there are some reasons why growth restriction leads to morbidity and mortality, which we should know. The intraventricular hemorrhage, bronchopulmonary dysplasia, necrotizing enterocolitis, infection, pulmonary hemorrhage, and hypoglycemia and hypothermia. We all know when you call SGA, the small for gestational age, when birth weight is less than 10 percentile, but you can have genetically small, which are constitutionally small, but healthy small for gestational age. And the Doppler is normal in all these cases. Whereas fetal growth restriction, the baby fails to achieve its growth potential. 50 to 70% of SGA fetuses are constitutionally small. Pathologically, when they are small, it is called as fetal growth restriction. They are about 30%. constitutionally small, the perinatal outcome is normal. No IUFD, no signs of adaptation, whereas fetal growth restriction, you will see poor perinatal outcome, intrauterine fetal death, and sites of adaptation on color Doppler. What do we monitor? It's not only color Doppler that we monitor in third trimester, but also so many things like for growth, serial biometry and growth charts, which are very important. There is no point in doing biometry alone without charting it on the growth charts. Fetal compensatory mechanisms. Then to predict hypoxia or acidemia, you have to do color Doppler, and you have to look at the environment continuously by either doing AFI, biophysical profile, CTG. What is important when you want to label somebody as a small for gestation is established gestational age. And for that, first trimester crown rump length is the most accurate means of dating. Then comes the various biparietal diameter, humeral length, abdominal circumference, etc. The accuracy is plus minus 7 to 10 days, especially in earlier pregnancy, and in last trimester, it is 2 to 3 weeks. How to do and all that I'm not going to details into, but you should know where exactly to take head circumference, BPD, abdominal circumference, etc. Alteration of placentation has an important impact upon fetal growth. The most affected being abdominal circumference, as we all know, while the biparietal diameter and femoral length are less modified, as you can make out from these charts. How do you sonographically diagnose SGA? Estimated fetal weight calculated by serial BPD at CACFL. When it is less than 10 percentile for that particular gestational age. Not all SGAs are growth restricted. Not all FGR have birth weight below 10 percentile, and even 10% of appropriate for gestational fetuses may be growth restricted. That is why dynamic evaluation of the fetal growth is very important to find out the trend, whether the growth is increasing or not. Identification of a slowing down or stopping of the growth is very important. Measurement ratios are also equally important, like HCAC ratio. If it is more than 2 standard deviation above the mean, it is predictive of IUGR, and FLAC ratio above 23.5 is also considered abnormal and suggests IUGR. Abnormally elevated FLAC and HCAC ratios indicate asymmetrical growth and differentiate growth restricted fetuses from constitutionally small fetuses, where you will find both HCAC and FLAC normal. There is something called as the extended definition of fetal growth restriction, and it includes 3 parameters. One, estimated fetal weight less than 3rd percentile, cerebroplacental ratio less than 5th percentile, uterine artery PI more than 95th percentile. So fetal growth restriction is equal to estimated fetal weight less than 10 percentile, which we normally look at, plus any one of the 3 above. If you see a placenta, you cannot really pick up growth restriction. But if you see grade 3 placenta before 34th week of gestation, or you see grade 3 placenta when the fetal weight is less than 2.2 kg, you may suspect it. We all know that the amniotic fluid volume is restricted in growth restriction, and it is usually in the oligohydramnios. And this is the chart you must follow of AFI at different gestational age. Color Doppler detects deterioration of fetus at least 10 to 15 days before modality is available to us that can detect intrauterine fetal distress, like cardiotopography, fetal biophysical profile, etc. By color Doppler, we try to find out the cause, whereas CTG, fetal biophysical profile, detect the effect, and it is better to detect the cause than to wait for its effect to prevent delay in management. The Doppler, basically in cases of IUGR, is to identify etiology, whether it is placental, non-placental, identify hypoxia and fetal adaptation, plan timing of delivery, and identify fetuses at risk of perinatal complications. Basically, we do Doppler to identify vascular bed resistance in the uterine artery, umbilical artery. To identify fetal adaptation, you do middle cerebral artery, and to identify cardiac decompensation, you use either the umbilical vein, Doppler, or ductus venosus. Now, there are two distinct entities, early fetal growth restriction and late fetal growth restriction, which are distinct by a moment of onset, evolution, Doppler parameter modifications, and postnatal outcome. The best cutoff between the two fetal growth restriction form is 32 weeks in terms of perinatal outcome. The antenatal diagnosis, treatment, and timely delivery could diminish the risk of these two significantly. When you talk about early fetal growth restriction, we have something called as Delphi consensus. When you must have the gestational age less than 32 weeks, absence of congenital anomalies, and abdominal circumference or estimated fetal weight less than third percentile, or umbilical artery showing either absent end-diastolic flow or abdominal circumference or estimated fetal weight less than 10 percentile, combined with uterine artery PI more than 95th percentile and or umbilical artery PI more than 95th percentile. Please remember this very clearly when you want to call it as early IUGR and late IUGR. Delphi consensus as regards late IUGR includes gestational age more than 32 weeks in absence of congenital anomalies, abdominal circumference and estimated fetal weight less than third percentile, or at least 2 out of 3 of the following. Number 1, abdominal circumference estimated fetal weight less than 10 percentile, abdominal circumference estimated fetal weight crossing centiles more than 2/4 on growth centiles, or cardioplacental ratio less than 5th percentile, or umbilical artery PI more than 95th percentile. Early onset IUGR is considered to be a vascular disorder due to abnormalities of the tertiary venous vessels. It is more frequently encountered in patients with preeclampsia, autoimmune disorders, or other conditions that can affect the placental vessels, whereas late FGR is not associated with preeclampsia. In early FGR, the evolution is long enough to permit the development of a classical fetal asymmetric hypertrophy that can be diagnosed on ultrasound. This long evolution is mainly due to small oxygen demands of the fetal brain and to the long resistance to hypoxia of the fetal heart at this age of gestation. So what is the pathophysiology of IUGR? Reduced transfer of oxygen nutrient towards fetus, blood flow redirected towards the vital organs of like brain, heart, and adrenal glands, and reduced blood flow to muscle, bowel, liver, and kidneys. So there are progressive changes in Doppler alteration in early fetal growth restriction, which are very typical of early fetal growth restriction. What are they? Abnormal blood flow in placenta due to vascular lesions, increased resistance in the umbilical arteries, determine peripheral fetal vasoconstriction, and augmented umbilical artery pulsatility index. Then you can have cerebral vascular flow showing you decreased resistance to the flow of the blood in the middle cerebral artery. The MCA pulsatility might be reduced. There is absent end-diastolic or reversal of flow in umbilical artery. As it progresses, the growth restriction progresses. Abnormalities in pulmonary and aortic outflow tract with cardiac insufficiency. And lastly, overload of the precordial venous system with A wave, either absent in ductus venosus or reverse in ductus venosus. This is normal umbilical artery blood flow, as you can see in second and third trimester. This is a raised resistance to the flow of the blood in umbilical artery. PI has gone up. And this is the absent one on the left side shows you absent end-diastolic flow in umbilical artery. One on the right shows you reversal of flow in umbilical artery. Now, absent umbilical artery blood flow is the one when you should be alerted, and you should try to decide further line of action and the mode of delivery, where to deliver, when to deliver, etc. Whereas when we see a reversal of end-diastolic flow in umbilical artery, you have to deliver the baby as early as possible. Now, umbilical artery waveform, what is important that is impedance is increased in umbilical artery. 60% of the placental vascular bed is obliterated. If you see absent end-diastolic flow or reversal of end-diastolic flow, then it is associated with 40 to 70% perinatal mortality, respectively. This is middle cerebral artery. The one on the top, that graph shows you the normal middle cerebral artery, whereas this shows you abundant blood flow in the end diastole. That is not good. Please remember that. Okay, that shows you the compensatory mechanism that is going on in the middle cerebral artery. Middle cerebral artery, if it is less than 5th percentile, it is an efficient tool for evaluation of cerebral vasodilatation. And when you do CPR, how do you calculate cardioplacental ratio? By doing ratio of middle cerebral artery PI divided by umbilical artery PI. If it is less than 1, regardless the evaluation method, it is associated with poor perinatal outcome. The odds ratio is almost 11.7. In early IUGR, you will find umbilical artery showing you high SD ratio, middle cerebral artery showing you low SD ratio or low PI. Okay, as you can see here. Now, as the growth restriction advances, nothing is done. You will find abnormal umbilical artery and MCA both. Doppler remain the strongest predictors of adverse outcome, with only marginal added benefit of ductus venosus as an independent risk stratification. Please remember this. CPR should be considered as an assessment tool in fetuses undergoing 3rd trimester examination, regardless of findings of umbilical artery and middle cerebral artery Doppler. Please remember this very clearly. There are discussions about utility of routine 3rd trimester Doppler ultrasound, as has been shown by Acharya in 2015, that you should not only go for 3rd trimester ultrasound, but routine 3rd trimester color Doppler of umbilical as well as middle cerebral artery. That's a ductus venosus normal, and that's the reversal of A wave in ductus venosus. Ductus venosus allows the most accurate interpretation of fetal cardiac function as well as myocardial hemodynamics. And before ductus venosus shows abnormality, you have aortic isthmus Doppler, which will show you deepening of or reversal of wave, which is much deeper than normal. Uterine artery Doppler may be performed at any time of around 17 to 22 weeks in women with following risk factors, like all high-risk pregnancies. We are not going to talk about it as we are going to restrict ourselves to 3rd trimester, and it has already been covered by Dr. Bela. Women with an abnormal umbilical artery Doppler at 20-24 weeks defined as pulsatility more than 95th percentile and or notching, sorry, not umbilical, uterine artery, should be referred for serial ultrasound measurement, fetal size, AFI, BPP, with umbilical artery Doppler commencing at 26th week of gestation. Now, you can have a uterine artery also giving you some suggestion about growth restriction. That likelihood ratio, when you have abnormal uterine artery PI, if it is abnormal, the possibility of IUGR, the likelihood ratio is 3.7 times. That of preeclampsia around 5 times, and perinatal death 2.4 times compared to normal. This is a timeline of fetal hypoxia, from abnormal growth to abnormal arterial Doppler to abnormal venous Doppler and to abnormal cardiotopograph and BPP scoring. That comes last. So please remember the effect, the cause comes first before the effect. And you have, depending on what you are looking at, either up to 2 weeks or even 1 to 2 days. Coming to late FGR, In most cases, the placental lesions have a late onset and or do not have a significant extent in order to increase the resistivity of the placenta and translate it into augmented umbilical artery PI. Please remember this slide all throughout your life, that there is lesion, but it is not significant enough to give increased resistance to the placental vessels and hence translate it into raised umbilical artery PI. In terms of frequency, late FGR is far more prevalent than early FGR. It has placental anomalies such as venous immaturity. Please remember this, with less impact upon placental resistance. Therefore, the umbilical Doppler normalization indices remain unaffected. Diagnosis of late IUGR is more difficult due to large variability of fetal parameters on growth charts in third trimester. We all know that. In fetuses with late FGR, estimated fetal weight appears to remain within limits for appropriate gestational age fetuses at more than 10% at times. So, late FGR can be suspected when individual growth curve slows down or even becomes flat, number one. An increase of HCAC ratio is detected in a previously normal growing fetus. And the classical sequence of Doppler, which you would see in early growth restriction, you will not see in late Doppler cases. Please remember this very clearly. What we see in early FGR, all those changes in umbilical artery, middle cerebral artery, ductus venosus, etc., you will not see in late IUGR. During last 20 weeks of pregnancy, the brain increases in size by 17 folds. Please remember this. Late onset FGR fetuses are very fragile due to increased oxygen requirements of their brain. They present multiple risks due to their inability to tolerate hypoxia. The reactive cerebral redistribution in late FGR fetuses is associated with an alteration of the brain metabolism. Undetected fetal growth restriction in third trimester of pregnancy represents the main cause of unexplained stillbirth in low-risk pregnancies. Also, probably a number of idiopathic cases of cerebral neonatal palsy where an acute intrapartum hypoxia event could not be identified are in fact caused by an undetected late fetal growth restriction. What is important is middle cerebral artery PI. If it is less than 5th percentile, it is considered a marker of vasodilatation even in presence of normal umbilical artery PI. Please remember this, that you cannot do only umbilical artery. You must do also middle cerebral artery, because as I told you, umbilical artery might be totally normal. And if you're not an MCA, you will miss out a late FGR. You must do middle cerebral artery PI, because it shows you diminished resistance to the flow of the blood. Again, it's considered as late IUGR. A value of CPR less than 1 is used for diagnosis of cerebral vasodilatation. As I already told you, can be more precisely assessed by calculating multiples of median MOM for a specific age. A value of CPR less than or rather more than 0.675 MOM is considered to be associated with a significant cerebral vasodilatation. Late FGR fetuses are at higher risk of cardiovascular diseases, hypertension, glucose intolerance, diabetes, dyslipidemia, obesity in childhood and in adulthood. The rate of acute fetal distress during delivery and number of emergency C-section in late FGR with cerebral redistribution are significantly increased. CPR should be considered as an assessment tool in fetuses undergoing third trimester ultrasound examination, regardless of the result of the umbilical artery and middle cerebral artery measurements in cases of late IUGR. After 34 weeks, risk of serious morbidity and mortality is low, and the delivery of the fetuses with LFGR will minimize the long-term sequelae. Paradigm that a normal umbilical artery Doppler pattern in third trimester confirms normal pregnancy and doesn't need any further Doppler evaluation of other fetal vessels definitely needs to be modified with important impact upon the clinical follow-up. How do you manage FGR? There is no effective intrauterine treatment. That is the first thing. Objective of a correct management includes early diagnosis, prevention and reduction of risk factors where possible, and surveillance of the fetus with growth restriction. Delivery at the best moment. If delivery before 32 weeks of gestation, consider magnesium sulfate for fetal neuroprotection. If delivery before 34th week of gestation, corticosteroids should be given. Doppler ultrasound is the chief tool. What is the aim of delivery? Is whether you want a live fetus or you want an intact, survivable fetus. Risk of intrauterine compromise has to be weighed against the potential risk from iatrogenic preterm delivery. Antepartum ultrasound. What is the protocol for delivery in early IUGR? Early onset IUGR, growth restriction, fetal growth restriction, stage 1. Now, please again remember this very clearly. When you have a high resistance in umbilical artery, but CPR less than 5th percentile, middle cerebral artery less than 5th percentile, and uterine artery more than 95th percentile, all this will come in stage 1. Monitor with NST, physical profile in VAST weekly, umbilical artery MCA Doppler weekly, growth parameters A5 weekly, and delivery at 37th week of gestation. If everything is normal, you can do induction of labor, and vaginal delivery may be allowed if it is not contraindicated. Coming to management of early onset fetal growth restriction stage 2. This includes absent end-diastolic flow in umbilical artery or reversal of flow in aortic isthmus. If the gestational age is more than 34 weeks, steroids and deliver by C-section, even if it is more than 34 weeks. If gestational age is less than 34 weeks, admission, steroids, Doppler of umbilical artery MCA and ductus venosus bi-weekly, means twice a week, or even more frequently, and C-section if ductus venosus shows reversal of A-wave component. Coming to management of early onset fetal growth restriction stage 3. What is included in it? Reversal of end-diastolic flow in umbilical artery or ductus venosus PI more than 95th percentile. Gestational age, if it is more than 30 weeks, use steroids and magnesium sulfate. Deliver by C-section within a day or two if estimated fetal weight is salvageable. But if the gestational age is less than 30 weeks, decision according to the estimated fetal weight and NICU facility should be taken. And give rescue steroid magnesium sulfate if ductus venosus flow is normal. Do daily Doppler. C-section if ductus venosus shows reversal of A-wave or reversal of aortic isthmus with consent for intrapartum death. Coming to the last part, that is stage 4, early onset IUGR management. Pathophysiological correlate. There is a high suspicion of fetal acidosis. Criteria. Any one of these, the ductus venosus has reversal of flow, CTG with fetal heart rate decelerations, do 12-hourly monitoring, gestational age or more than 26 weeks. Mode of delivery should be C-section. Coming to late onset fetal growth restriction, the gestation age is more than 37 weeks deliver. Don't wait till term. Please remember this. You can allow vaginal delivery. Gestation age, if it is less than 37 weeks, give steroids. Doppler of umbilical uterine artery, if it is more than 95th percentile, CP ratio is less than 1, and estimated fetal weight of less than 3rd percentile. If any one of these three is present, consider delivery at any stage after 34th week. Monitor for serial worsening of middle cerebral artery, PI, if it is more than 95th percentile. Rather less than 5th percentile. Now, late FGR more than 34 weeks. Delivery at 37 weeks in case with increased PI of umbilical artery. Please remember that all throughout you are having umbilical artery normal. You had gone up to 37th week and you find umbilical artery showing increased PI. Don't wait for absent and diastolic flow in umbilical artery or reverse, you deliver. Delivery at 37 to 38 weeks in case of normal umbilical artery Doppler, but with modified middle cerebral artery. Timing of delivery is based on middle cerebral artery Doppler. Cases with normal umbilical artery Doppler or with abnormal umbilical artery PI, but end-diastolic velocity is present. And good obstetrical condition, induction of labor can be offered, but rates of emergency C-sections are increased. So to conclude about left IUGR, onset after 32 weeks, PIH need not be there. It is a high index of suspicion, which will make you understand that there is late IUGR. Umbilical artery Doppler may be normal. Always combine umbilical artery with middle cerebral artery Doppler, and the ultimate decision will be taken by you as regards delivery on CPR ratio, that is the cerebroplacental ratio. Differentiate between constitutionally small fetal growth and fetal growth restricted babies. Composite of growth curves like Doppler is important. Many so-called constitutionally small babies will be redefined as fetal growth restriction if you add cerebroplacental ratio. Uterine artery Doppler and estimated fetal weight will both below 3rd percentile. Doppler of umbilical artery, middle cerebral artery, ductus venosus, aortic isthmus are useful for monitoring and timing of delivery of fetal growth restriction. Pathological growth restricted fetuses have high morbidity and mortality rates and hence require much more intensive surveillance. Thank you very much, ladies and gentlemen, for giving patient hearing.
Thank you so much, sir. I would request Dr. Seetha Pal, ma'am, to give her concluding remarks on the talk. Over to you, ma'am.
Thank you, sir. Thank you, sir, for making such an complicated topic so simple. That is the hallmark of teacher of teachers. You've always, guided us so in all our matters, so explaining it so nicely and vividly. So thank you once again. And I really don't need to add anything more here. It's just that correct your dates. Don't change the ultrasound. Don't change the EDD once you've got it in the first trimester. And go on and do a multi-vessel Doppler whenever you are suspecting a growth restriction, as sir has rightly said. Thank you once again, sir, and we need all your blessings for all our journey ahead. Thank you.
Thank you, ma'am. Veena, ma'am, we would like to hear from you as well.
Veena is still there.
We don't need to add anything to Dr. what P.K. Shah sir has already said. He has been a guide, mentor, teacher since I did my ultrasound training at Vadia Hospital, sir.
Me too.
So, definitely, whatever you tell, we just need to follow. And I would like to again tell, as Dr. Bela said, all the obstetricians should start doing the ultrasound because the patients we are screening, we know the clinical history, we know her previous obstetric history. If we are able to do our own ultrasound, including Doppler, including ductus venosus, I'm sure we will be able to deliver much more better care to such patients rather than getting a report from outside. I'm not saying anything bad about the fellow people who are doing ultrasound, the radiologists, but definitely we ourselves doing for our patients, that it makes a big difference. And I think Dr. Prashant sir has joined. Ajay, I think Dr. Prashant Acharya sir joined.
Hi, Prashant.
Prashant sir, he had joined, but I think he
Is he
left
around?
again. Gorak Mandrupkar is there. GM. Gorak sir, are you there?
Gorak, I think so.
Gorak sir is there.
Oh, sir, unmute yourself.
Gorak sir is there. So just request him to say about and comment on Dr. P.K. Shah's talk and about Gestosis score also.
No,
As
because he has
preeclampsia
created
definite.
he has created that justice score. Gorak sir.
Good evening, and thank you.
Firstly, comment
Hi,
on
Gorak.
Dr. P.K. Shah, sir.
Hello.
Right. Yes, sir. Actually, it is very difficult and not to comment on sir's lecture because sir has given all the points. A very important message is what sir gave us, that unnecessarily do not complicate the ultrasound, the readings of the ultrasound, but make it very simplified. And as sir has told, and as well as Dr. Sita has told, I think everybody must start doing the ultrasound, and one should understand how to do the Doppler and how to do the correct readings of it and the clinical application of what sir has already told. So I am very proud here that sir actually in front of Dr. P.K. Shah sir to talk is really always an honor. And as taking the point ahead regarding the Gestosis score, again I am proud to say that when I challenged the guidelines of the FIGO,
You are mute again.
Unmute
Hello?
yourself, Doctor.
I'm sorry.
Yeah.
He was Dr. P.K. Shah sir who was there, and he supported me in Bhubaneswar when the Indian ICOG Foxy Gestosis guidelines, they were introduced actually at the hands of then Health Minister of Odisha. And I'm very proud to say that he is really a teacher of teacher, and he could understand what, though we are saying that yes, the Doppler and all these things are fantastic. Even now, some of the researchers are saying that doing all biomarkers, right? Today they're doing all and everything. But when we consider the Indian population, one must understand that it is not easy to do each and everything for all women just to predict the preeclampsia. And that's why.
You are mute again.
Sorry, it is disconnecting. So to end, just to remove all the confusions and all the guidelines, if you remember, let it be US guidelines, let it be Australian guidelines, let it be our WHO guidelines, let it be Indian guidelines, all have come to the conclusion that yes, it is the clinical risk factor based screening should be done for the prediction of preeclampsia. And that's why the HDP Gestosis score, which is a very simple thing. So it is a sincere request to all of you that please go on the App Store, Android App Store, and just download the HDP Gestosis score. Here it is not on the name of any organization. Gestosis means pathological pregnancy. So one must understand that it is the HDP Gestosis score. Second thing I would like to hear comment, last thing, because many of us are here and one must understand the take-home message regarding the dosage of the aspirin. The dosage of the aspirin, when we say low dose aspirin, it is 75 to 150. But nowadays only Fetal Medicine Foundation and the FIGO guidelines, they say that 150 milligram. But again, I would like to comment on that. It is been proved and very beyond doubt that 75 milligram aspirin is sufficient to prevent the hypertensive disorders of the pregnancy. There is only one paper recently on which these two guidelines are based. And if you see that paper, then you will realize at the end of the paper, the researchers themselves, they say that we have not come across and we have not tested the safety, the neonatal safety after the usage of 150 milligram of the aspirin. Second thing, there is no paper in the world which has compared the 75 milligram of aspirin is bad and 150 milligram is good. The paper which is available, it says that actually they have compared this with placebo. So the 150 milligram dose, which is been compared with the placebo, will we continue? The answer is no. Again, if we see the WHO guidelines, even NICE guidelines, they have not shifted to 150, but they say 75 to 150. The reason behind it is again, 1 to 1.5 milligram per kg body weight of the aspirin is sufficient to prevent the hypertensive disorder. It is not the dose of the aspirin, but it is the starting of the timing of the aspirin as early as possible is very important, because the upset, that is the defective trophoblastic invasion, is in the first trimester as well as in the early second trimester. So everybody must read. Even if you see the comments of Atalla on all these aspirin, please, it is my sincere request that we all should think again and again of the physique of our Indian women, the body mass index of our Indian women, the sufficient dosage of the aspirin, and then one must select the dose. Last thing, that please download the HDP gestosis score. It is not any private personal property. It is actually the guideline of FOXY, the guideline of the ICOG, and the guideline of the gestosis. The question here, Preeti Madam has asked, how long aspirin should we continue? And the answer is, we should start as early as possible, maybe right from first trimester, till 2 days prior the labor induction or the elective cesarean section. All of you will agree that the 75 milligram dose never alters the bleeding profile, the coagulation profile. That's why even if the aspirin is continued, and even if we have used the regional anesthesia, it never causes any problem. Even in cases of threatened abortions, there is no need to discontinue the 75 milligram dose. And that is the beauty of the 75 milligram dose, which is sufficient to balance the thromboxane A2 and prostacyclins. Thank you. Thank you very much, Dr. Ajay Mane sir, Dr. Pardeshi sir, and Dr. PK Shah sir, and the Buldana OBGY Society for just actually, I'm a guest. I have talked for more than 2 minutes, which is not right. But because the subject was going on and I was listening, all of you have given the wonderful talks. Dr. Bela Madam, Dr. PK Shah sir, so we cannot say anything about you, sir. It is you are the god of the sonography. But I wanted to share these things because one must understand what are the Indian guidelines. And the last thing regarding Ajay Mane sir's talk. He is talking like anything. He is delivering us since so many years that please maintain the documents and all. Yesterday only I was with one of the director of health services, and he again complained that, sir, आप lectures में इतना बताते हो, Ajay Mane sir and Dr. Pardeshi sir तो इतना बताते हैं, but in Dhadak Mohim, which is going in Maharashtra, almost more than 80% of the doctors, they are with bad records. So though we are saying again and again, it should not happen. So it is a sincere request that the persons like Ajay Mane sir should be there, who will take care of all of us from the legal point of view. So thank you very much, sir, and thank you very much all. Over to you.
Thank you so much.
Thank you, Gorakh sir. Thank you very much.
Thank you so much, everyone. Now I would like to invite Dr. Vinod Rajankar, Secretary, Buldhana OBGY Society, to give vote of thanks. Over to you, sir.
Thank you, Mrs. Karishma. Good evening, honorable guests, chairpersons, faculties, organizers, and delegates. I, Dr. Vinod Rajankar, Secretary, Buldhana OBGY Society, privileged to extend my gratitude towards the dignitaries. First of all, I am thankful to to respected Dr. P.K. Shah sir being chief guest for this webinar. I am very much thankful to our guest of honors, Dr. Prashant Acharya and Dr. Rajendra Singh Pardeshi sir for their auspicious presence and sharing their thoughts. I extend my gratitude to Dr. Ajay Mane sir, convener of this session. I am thankful to Dr. Sadanand Ingre sir providing me this opportunity. I should mention deep meaning of appreciation for our faculties, Dr. Archana Patil, Dr. Bela Bhatt, Dr. Ajay Mane, and Dr. P.K. Shah sir for excellent coverage of their topics. We are grateful to our chairpersons, Dr. Sitar Ramamurthy, Dr. Sujit Konkar, and Dr. Veena Panar for their experts comment. I am most thankful to Dr. Yashwant Gade sir, MMC Observer, for his great gesture. We are very much thankful to Dr. Stalin, Shield Healthcare, for providing this platform. I appreciate MOC Mrs. Karishma for her flawless conduction of webinar. Last but not least, I am very much thankful to our delegates for their active participation. Thank you. Thank you very much.
Thank you, sir. Thank you very much. And I am very much thankful to PK sir because he has given 3 hours today. It is a great thing in spite of such a busy schedule. Thank you, sir. Thank you, Sita ma'am. She is also has given 3 hours in busy hours. And Bela, thank you very much. And Vinod sir and English sir. Thank you, sir. Thank you very much. And our own Pardeshi sir. So permanent thank you to Pardeshi sir.
Thank you for involving me. It was an excellent session.
Thank you.
Thank you. Thank you. Thank you very much. And
thank you. All your wishes.
Thank you, Chitrakala, and thank you, Dr. Stalin. Thank you, Sita madam, for your wishes.
Thank you.